So as Deborah said, I'm at Vanderbilt University. I'm a professor of neurology. I've been at Vanderbilt for a little bit over 10 years. And I, shortly before moving to Vanderbilt, my second son was diagnosed as possibly being on the autism spectrum. My first son had been diagnosed when we lived at the University of Michigan. And I was a sleep specialist, actually an adult sleep specialist who saw an occasional child, but didn't really do anything with autism or neurodevelopmental disorders. I really focused on adult sleep, but that really changed everything when my kids were born. And I look at it as a blessing for them. I look at it as a blessing for me that I became involved in this area and in this field. And it's a very exciting time in autism and autism research, you know, with the increased prevalence, with a lot of new ideas, a lot of new thoughts, and a lot of new treatments and interventions. And one of the things that you'll hear me talk about today is how when we're sleeping better, and when a child is sleeping better, and when a family is sleeping better because the child is sleeping better, it can make a huge difference. So it goes even beyond sleep interventions to say, well, if you're sleeping better, if you are, as a parent, you can be a bigger advocate for your child. Your child can be more engaged and involved in therapies. So it really is, to me, sleep is a pivotal part of the intervention for autism. And we'll also talk about how sleep might actually be a marker of certain types of autism or help us understand autism better. So I hope to cover kind of a broad group of things today. The questions we'll address today include what sleep concerns have been identified in children with autism spectrum disorders, which I'll refer to as ASD. What are the causes, ranging from, on one end, the neurobiological, on the other end, the behavioral, and that doesn't necessarily mean bad behavior. It means things we do that can impact on sleep. And then the medical is in there as well. And what is the impact of sleep disorders and their treatment on autism? How do we screen for sleep disorders? How can you partner with your healthcare provider? As Osman was saying, how do we work together as a team to make this work? And then what treatments exist for sleep disorders in autism? I'm going to focus on behavioral treatments, but I'll mention medical as well, and how behavioral and medical can go together. And then hopefully we can have an interesting discussion on how we implement these and what's useful to parents, because we're still learning what that is. You might have seen in your handouts that we're coming out with a book this fall, hopefully this summer. By all means, if it isn't this summer, it'll be this fall. And the impetus behind writing this book is we wanted to fill the gap where a lot of parents have said to us, we don't know how we're going to get training in behavioral sleep education. The pediatrician's office is busy, not necessarily here in Vancouver, but in Nashville and the States. There's so much to do. There's so many things the pediatrician has to cover. Can we have a resource? So that's what that book came out of, and we're really interested in hearing from you all what might work in your situation, because we are still discovering and still trying to identify the best way to get the principles I'm going to talk about today out to parents across the North America in a way that works for them and is practical. So just to bring everyone up to date, many of you in this room are already familiar with autism, but there have been some changes recently. The core symptoms are impaired social interaction, impaired communication, and restricted interests and repetitive behaviors. And with the moving from the DSM-4 to the DSM-5, which is a classification of different diagnoses used in psychiatry, the impaired social interaction and impaired communication have been put together. So now there's two bullet points rather than 3. One is the impaired social communication, how a child interacts with the world, and then this restricted interest, repetitive behaviors category. And this really is a spectrum. It can be the child in their own little world, as you can see here, that they are socially withdrawn, they're really keeping to themselves. But it can also be a highly outgoing, gregarious child who's socially awkward and just doesn't know how to interact normally with the world. And I keep using child. It is important to realize, as Deborah was saying, she now has a grown child and a grown child who's now an adult. And I have one is about to be a teenager in a month. My children are 12 and 15. So if I say child, you can try to remember that I really mean young adult as well, teen as well. And this can, over time, we oftentimes see improvement and individuals on the spectrum compensating, but these core deficits really do remain and tend to be lifelong. And the other thing that can go with the spectrum is it can be a spectrum in language. Some individuals can be nonverbal, others are highly verbal. IQ, there can be intellectual disability, others can be normal or actually superior intelligence. And there are many medical comorbidities or coexisting conditions, including epilepsy, which is seizures, and I'll show you some examples of that later this morning. GI disturbance, gastrointestinal disturbances such as reflux, constipation, anxiety and other psychiatric conditions, OCDs, obsessive compulsive disorder, ADHD, attention deficit hyperactivity disorder, and then sleep disturbance is very common. About 50 to 80% of individuals with an autism spectrum disorder have difficulty with sleep. And it's really interesting because we don't quite know why there's such a high prevalence of sleep disturbance as well as some of these other comorbidities. And one of the theories is that there's over stimulation of the brain and over connectivity. Another theory is there's a hyperarousal disorder where being over-aroused, overstimulated is driving these behaviors so that you have insomnia because you can't shut your brain down, you have anxiety, you may have GI disturbances. So there's different theories that are being tested and monitored. But these are all very common. And the interesting thing is, from a clinician standpoint, is the sleep disturbance intrinsic to autism or secondary to some of these comorbidities? Because we know that seizures, GI disturbances, anxiety, OCD, ADHD can all in and of themselves disrupt sleep. But then the flip side is really interesting too, right? Because could we affect these comorbidities and coexisting conditions as well as some of these core symptoms by improving sleep? So to give you some examples, if a child is sleeping better, we oftentimes see that seizure control is better. They don't have as many seizures. We find that the number of medications they need to control their seizures may be less if they're sleeping better. And then the daytime sleepiness that they're having from being on all of these strong epilepsy medicines is not hitting them as hard if we treat a coexisting sleep disorder. And a good example of that is sleep apnea. If you have sleep apnea and you're waking up multiple times a night to breathe and to catch your breath, and then on top of that, you're taking strong medicine for epilepsy, you're going to be very sleepy during the day. So focusing on sleep can really help, particularly in individuals who have some of these medical coexisting conditions like epilepsy. Another interesting one is anxiety. Anxiety can make it harder to go to sleep at night. You're anxious, you're scared. But then if you sleep better and different strategies can be put in place to help you sleep better, then your anxiety may actually dissipate. You may be less anxious during the day. You may be able to, it's kind of like a positive circle, not a vicious circle, but a positive circle where you break an association and then you find that everything improves. So we'll talk more about those issues today. And then the core symptoms, it's interesting, particularly this ability to interact in therapy and learn in therapy how to interact better with the world, like in behavioral therapy. If a child comes to the therapist grouchy and grumpy and aggressive and irritable, you're not going to be able to get as much done if they're sleeping better. So the idea of using sleep as a means to improve the child's ability to work in a therapy session is very exciting to me, as well as the parent's ability to be an advocate for their child, because the parent is actually sleeping better too. And how many people in this room are parents, even if you're other things? I mean, do we have a lot of parents? Okay. So we all know, I used to think it was really interesting when I would be really tired, I would be really grumpy, I had been sleep deprived, and my kids would be acting up, especially when they were little. They still act up, but when they were really little. And I was thinking, darn, the timing is so bad here. I'm tired, and they're tired, and I'm tired and they're acting up. And then one day I made the connection between the fact that, when I was grumpy and irritable, because I was tired, it was making them grumpy and irritable. And when I modeled, when I slept better and I modeled better sleep and being more alert during the day, they were less irritable. And that's when I realized everything is really connected. So some of the benefits on the child, I've come to think, are not only because the child is sleeping better, but because if the child's sleeping better, the parents are sleeping better because they're not getting woken up, and then they're able to interact with their children in a more, a more effective way. So lots of benefits here, I think, to treating sleep and thinking about sleep that go beyond sleep and get into both the child behavior during the day and the parents as well. So with that said, sleep is one of the most common concerns that parents of children with autism will bring to their medical provider. I said about 50 to 80% of the time. And what's really neat is the sleep community, whether it be the American Society for Sleep Medicine or American Academy for Sleep Medicine or the National Sleep Foundation in the US, and I know you have similar groups here, has really identified autism as a priority population for targeting interventions for sleep disorders for the reasons I mentioned, the child health, daytime functioning, the family, and they're very treatable, as I hope to show you today, that sleep disorders, whether there's a medical cause or a behavioral cause, are very treatable. But how do we do it? How do we screen for sleep problems? How do we evaluate for sleep problems? And how do we treat problems in children with autism is really not there yet. And that's kind of where we need to go. So this is just a slide showing the prevalence, about 50 to 80%. For the most part, objective measures have borne out parent concerns, and we'll talk about later this morning what is a sleep study, what is polysomnography, what is actigraphy. If you look at the percentages, it's higher than in typically developing. TD is typically developing children, so kids with autism have more sleep problems than typically developing. And it's all across the spectrum. So we now call it Autism Spectrum Disorder, but you've probably heard about the Asperger and the PDD-NOS, pervasive developmental disorder not otherwise specified, autistic disorder. So regardless of spectrum diagnosis, sleep disorders are highly prevalent. Regardless of cognitive level, sleep disorders are highly prevalent. And this has been shown in multiple studies. In our, so what is the Autism Speaks Autism Treatment Network? You'll hear about it today. If you pick up the brochures, you'll see the ATN and then the AARP. I just wanted to mention what it is. Autism Speaks is a large parent advocacy group. that funds quite a bit of research, particularly in U.S. and in North America. One of the programs of Autism Speaks is the ATN, or the Autism Treatment Network, and it was developed to focus on medical issues facing children with autism. And now we're starting to look at adolescents and young adults as well, because the emphasis has been on genetics, the emphasis has been on some of the more obscure causes, and they wanted to be very practical and really focus on these medical concerns. And the reason that I've been so involved in the Autism Treatment Network is because sleep, as I mentioned, is one of the major medical concerns that parents voice as a concern. So they have funded a site at Vanderbilt on which I serve as the principal investigator. I also am co-chair of the Autism Treatment Network subcommittee, which is 17 sites across the country, and we bring the sleep specialists together on the phone once a month, and we develop projects and toolkits. We developed a practice pathway, which I'm about to show you, for how to evaluate and treat and monitor kids with autism who have sleep problems, and we've also developed these booklets and toolkits and quick tips. This is the one that just came out last month. We're really excited about it. It's for teenagers with autism. So I'm really excited. They're available free of charge on the Autism Speaks website, and you should have some hard copies that you can pick up today. And one of the things we did early on is we took our registry, because one of the things that Autism Treatment Network is doing is enrolling kids in a registry, a research registry, so that we can look at patterns, we can look at medical issues, we can track what's happening over time. And we had more than 4,000 kids enrolled in the registry in March of 2012. We had, of those, more than 3,500 parents who completed the CSHQ, the Children's Sleep Habits Questionnaire, which is one of the questionnaires in your booklet. And then these are the domains on the CSHQ: bedtime resistance, sleep onset delay, night wakings, sleep duration, sleep anxiety, as well as parasomnias, which we'll talk about later this morning, are unusual movements or behaviors in sleep, sleep disordered breathing, and daytime sleepiness. We found that 2438 parents endorsed sleep problems on this questionnaire, so there's 68%, and which matched up with what had been described in the literature in smaller samples. This was a really large sample. And we found a mean on the Children's Sleep Habits Questionnaire of 47, which was much higher than what was seen in typically developing children without sleep problems, which was 41. And then we found no differences based on gender, age, diagnosis. Again, this was the PDD-NOS versus Asperger's versus autistic disorder, or IQ. So across the spectrum, sleep problems were prevalent. And of sleep problems, the most prevalent concern is insomnia. And insomnia has been defined as repeated difficulty initiating sleep, the duration of sleep, the consolidation or how solid your sleep is, the quality of sleep that occurs despite having age-appropriate time and opportunity for sleep. So this isn't the teenager who doesn't have enough time to sleep because he's working too hard on his homework, and then he's going out with his friends, and then he's, getting up early for school. This is actually having difficulty falling asleep despite having enough time, or night wakings, or some of these other things that are listed here. And then there's also got to be some daytime functional impairment for the child and or the family. So these are how sleep insomnia can manifest: difficulty, prolonged time to fall asleep, preference for a delayed bedtime in the older children, bedtime resistance in the younger children, sleep anxiety, decreased sleep duration, increased arousals and awakenings, or waking up really early in early morning wake time. And the causes are really quite almost a spectrum themselves, quite different and diverse. At one end, we have the biological, the neurotransmitter abnormalities, melatonin, probably have heard of. We'll talk more about melatonin later this morning. GABA, serotonin. These are brain chemicals that have been shown to be altered in autism that also affect sleep. Medical, I've already alluded to GI problems and seizures, which can contribute to waking and insomnia, as well as some of the psychiatric conditions. And then the medicines that we use to treat depression, to treat anxiety, to treat ADHD, to treat seizures can oftentimes contribute to insomnia. Sometimes they also contribute to daytime sleepiness, like the anti-epileptic drugs. Just because a child has autism does not mean they're immune from having other sleep disorders like sleep apnea, the parasomnias, which are the abnormal movements or behaviors in sleep, restless leg syndrome, which is one of Osmond's big interests. We'll talk a little bit about that later this morning. What's interesting about restless legs is there's a nutritional link where if you have low iron from either a restricted diet or being on a certain type of diet, you can have that develop. And then the behavioral category, which was really near and dear to my heart. Again, it's not bad behavior. It's actually linked to autism itself. In other words, we know that children with autism have difficulty with emotional regulation, transitioning, going from one activity to another. If their routine is disrupted, it can be very hard. They might have a meltdown. Also, understanding parental expectations regarding sleep. It's a communication disorder. It's a social communication disorder. So kids with autism don't always know what the expectations are. And their parents, many of you guys, have so much on your mind and there's so much going on that thinking about implementing a bedtime routine, I mean, you're exhausted. You're just trying to do what you can for your child and be your best advocate for your child. And it can be very overwhelming, particularly when you read a book on, well, if you just let your child cry and don't go right back in, they'll soothe themselves to sleep. It can be very overwhelming. And so really focusing on this category and figuring out what is specific to the child and realizing that the child with autism does not necessarily fit the mold of a typically developing child, where maybe leaving the room and letting them sort of work it through and fuss a little is going to work, is not necessarily going to work for the child with autism, is very, very important. So coming up with new strategies, coming up with things that work for the family. And this is where I probably need to just take a step back and say, I've been doing this for years and families really oftentimes respond to me, but I was in clinic a few weeks ago and it was very humbling because I did all of this with a parent. I had extra time. I took my time. I made her a bedtime routine. I pulled out the Velcro. We figured out what worked for her and her family. And she looked at me and she just started crying. And I said, what did I do? And she said, well, I really appreciate everything you're doing, Dr. Mallow. Your efforts are really appreciated. I know you're trying, but I can't make this work. I'm divorced. My child is with my ex-husband a lot of nights. I don't know what goes on there. I'm trying to make ends meet. I'm trying to work this job. The ability to sit down and really put a bedtime routine together and put all these things in place, it's just not going to happen right now. And can you please give me a pill, And it was very humbling because I realized that, and she was telling me I had the best of intentions, which was nice, but I was really feeling like, here I am I immediately called my colleague who's working on this book with me, Terry Katz at University of Colorado, and I said, Terry, we have to have a chapter called How to Work in the Real World, and we actually did modify some of our cases to be more real world, but it made me realize, and I really want to say it, before it goes too long today and we get too much into the material, you do what you can, and it's not unusual for me to meet a family for the first time in clinic, rule out the medical things, make sure I've ruled out sleep apnea, order a sleep study if I need to, do all of that, and then come up with like one thing for them to work on. And it might be, child comes home from school at 3 p.m., don't let them go into their PJs right away, keep them in their street clothes until you start the bedtime routine, then put them in their PJs so then they start, realizing it's bedtime. I mean, it may be one thing that the family can work on, and then when they come back in a month or two, you can introduce something else. And that is something I really want to impart. Is the last thing I want to do today is overwhelm you with any of this, because a lot of times it really is a matter of meeting the family where they are. And, sometimes it's a new diagnosis, and there's so many different things to do. And sleep falls by the wayside, even though sleep could be the trigger for meltdowns, aggressive behavior, impulsive behavior. But sometimes we have to really work with families and say, this is all they can do, and this is all we're going to be able to do for now. So why do we sleep? We sleep because sleep restores. This is one theory. There's many theories, but the theory that's getting the most press these days is sleep restores and repairs what's lost in the body when we're awake. So emotions, cleaning out clutter, managing sensory overload. There's a lot of emphasis right now on sleep and how sleep does these wonderful things to restore the brain. And this is very relevant to autism because people are now feeling it's a disorder of overconnectiveness or hyper arousal. So one of the reasons that sleep may help our kids with behavior during the day is because of this restorative theory. This is an example of the biological. And then what are some of the consequences of not sleeping? There's a very big literature in typically developing children, particularly with sleep apnea, where if you have sleep apnea and your sleep is disrupted, you can have ADHD type symptoms, attention deficit hyperactivity symptoms, and when you treat sleep apnea with adenotonsillectomy, it can help the ADHD symptoms. So that's the model that we've used, even though kids with autism don't necessarily have a lot of apnea. They may have some, but it's not necessarily more prevalent than in the typically developing population. But there are clues that this not sleeping well can contribute to more problems during the day. Schreck and al. Had found that short sleep duration was associated with greater autism symptoms. Again, this is chicken versus the egg. Maybe it's not that the sleep problem is causing the autism symptoms entirely. It may be that the autism symptoms are contributing to the sleep problem, or that something is driving both. Gabriel's found that the presence of sleep problems was associated with repetitive behaviors, although this effect appeared mediated by nonverbal IQ. And then Du and Wing, using the Parenting Stress Index short form and the CSHQ, showed that the presence of sleep problems was associated, not surprisingly, with higher levels of parenting stress. So how do we develop standards of care? This gets to that practice pathway I mentioned that we developed in the Autism Speaks Autism Treatment Network Sleep Committee. And it's for the surveillance, the diagnosis, and the treatment of insomnia in ASD. And the surveillance diagnosis part is where healthcare providers ask families about insomnia and review targeted questions from the CSHQ. And then the specialists also address potential medical issues that may be contributing to insomnia and refer as needed to a medical or sleep specialist. The treatment part, we always start with the behavioral as a first-line approach. We'll talk about why that is later. But autism specialists and their team will then provide the family with behavioral sleep education. And that's the part we're still working through. Sometimes it's a book, like the book we're going to be publishing, or other books that are available out there already. Sometimes it's a pamphlet, like the pamphlets you've picked up today. And sometimes it's an intensive session with a behavioral therapist or a nurse in the pediatrician's office. And then plan B is if the behavioral approach doesn't work, we will use medications in conjunction with behavioral therapy with referral to a sleep specialist as indicated. So this is a busy slide, but I was able to break it into a few different parts. So the screening part, you might find it small in your handout. The screening part is basically looking at whether the child has any symptoms of insomnia. And there's some numbers in here, B6, B8. Those just refer to the CSHQ. But the important thing for you to know is it's asking the parent specific questions about how long does it take your child to fall asleep, night wakings, are they co-sleeping, which could be a cultural preference, but in a lot of kids with autism, parents are co-sleeping out of necessity. They're worried their child is going to wake up. They're worried about safety issues. So we ask about those kinds of things. And then that's the screening part. And then in the second part, we assess and treat. And there's two parallel paths, as you can see here. One of the paths is the, let's see if I can put the mouse on, and I think that works, yeah. So one of the paths is the whole medical contributors path. Are there medical contributors like GI problems, sleep apnea, and that can be addressed and treated. And then the second path is the insomnia toolbox or the sleep education path, the toolkit path. And that's assessing whether the family is able and willing to use an educational approach, initiate sleep education, and then either follow up with the practitioner or consider consultation to a sleep specialist if the family is unwilling and unable to use an educational approach. And that might be where medications come in, or a more intensive behavioral program. And then the next one, which is equally important, is the consulting and referring to other providers as needed. And then if the insomnia is resolved, you're done. But if it's not done and you've made these consultations and you've considered sleep medicine, you've considered a referral to a sleep specialist for insomnia, we follow up. We make sure that we circle back, that the family is doing better. And if they are, you're done. But if they're not doing better, you go back and you try to assess, did I miss a sleep problem? Do I need to do a sleep study? What's going on with the family? So this is what we came up with, and it unfortunately is not based on lots and lots of data. It was more of a consensus because the work and the data are just not out there yet. I mean, what we really found was that there were no Food and Drug Administration, the FDA, drugs for insomnia. We were really going with a lot of empirical or consensus-based advice, and flexibility is obviously the key. And as I mentioned, the follow-up is really important. Essential to follow up with the family to see if the sleep intervention you've put into place is effective. And if the child is not responding, consider consultation, referral to the sleep specialist, consider a trial of medication for sleep, be sure to follow up the children, and then consider repeating everything in another year. And then the screening, these were the questions that I mentioned earlier: falling asleep within 20 minutes after going to bed, falling asleep in a parent or sibling's bed, the child sleeping too little, the child awakening during the night, as well as other screening questions that get at some of these medical comorbidities like snoring. And other sleep questions could be used as well. So this is one. This is the Children's Sleep Habits Questionnaire that's in your booklet, and we're going to have some of you fill this out over the break. It's 45 items. The subscales are listed here. And the parent basically lists whether for each item, how frequently is it occurring and is it a problem or not? So using the is it a problem or not, it's very easy to just scan through and say, okay, these are the things that the parent is most concerned about, and then address them. But it's important to realize there are other sleep screening questionnaires out there besides the CSHQ. This is the BEARS. B is for bedtime problems, Z is for excessive daytime sleepiness, the A is for awakenings during the night, the R is for regularity and duration of sleep, and the S is for snoring. So this in some ways may be easier, particularly for a practitioner to use, just kind of off the tip of their tongue because they can remember the mnemonic, the BEARS. And then this is a completely different type of sleep questionnaire, but complements the work of the Children's Sleep Habits Questionnaire, or the BEARS. It measures sleep hygiene. It's called the Family Inventory of Sleep Habits. And it asks, here I'm showing the 12 questions that we used kind of in our validation study, but the one that is in your book is longer and asks even more questions. And asks about exercise, asks about the consistency of the wake-up time, asks about stimulating activities or relaxing activities before bedtime, asks about caffeine. So again, the practitioner or the parent, if you're filling it out, can get a quick assessment of what areas the child potentially could be worked with or trained in to help sleep. And then sleep logs or diaries are also oftentimes very helpful as well, because they can actually chart out when a child is asleep, when they wake up, and give the parent a really good visual that they can then discuss with their healthcare provider. So I'm going to stop here and see what questions you might all have.
Time is always an issue for parents as well as professionals. How would you suggest to use the questionnaires? How would you rank them? How would you start? We here suggest using the BEARS as a concept and bringing the other things later on in. Would you agree with that, or do you have another suggestion?
Right, so I think what Osmond is asking is, how can we practically use these? And I think it depends on the audience. So, oh, by the way, for the video person, it's okay that I stepped out behind the, okay, I just want to make sure. So, as a professional, let me start with the professionals and then I want to talk about the parents. So, as a professional, nurse, physician, nurse practitioner, therapist, the most important thing, I think, is ease. And how do you do this in a busy practice? And that's why I brought up the BEARS. There are other examples as well. But I wanted to bring that up because you may have 2 minutes. Like in the U.S., pediatricians, and I think it's similar here, there's the American Academy of Pediatrics has all these different things they want you to do in your time with the child, your half an hour with the well visit with the child, all sorts of screenings. So the idea is if it's not a quick and easy screen, it's not going to happen. It's going to fall by the wayside. So for the professional, we need to have these options. And so in this Autism Treatment Network, there are these sleep specialists I mentioned, and we put all this together. But then we had to talk to our colleagues who are not sleep specialists, but are developmental pediatricians or other specialists who see kids with autism, and they were like, this is too much to do the Children's Sleep Habits Questionnaire. And that's why we actually came up with 4 questions on the Children's Sleep Habits Questionnaire we thought were important. But we also recognized that that could be too long and we needed to go with something like the BEARS or some other screening list of questions that they put together. And some of them put together, for example, we're going to ask X about sleep, we're going to ask Y about GI, we're going to ask Z about seizures, and then we're going to be done. We're going to have our very quick and simple set of questions. So that's for the professionals. I think the most important thing is to get sleep on their radar and have them asking about it. And if it's too long of a questionnaire, it may not happen. For the parents, one of the reasons I like the Children's Sleep Habits Questionnaire is it has that kind of yes and no column. So it's easy for a parent to be able to say, oh, these are the areas I'm really concerned about. When I go and I talk to my healthcare provider, I'm going to bring these up. Or if they give it to their therapist to look at, the therapist can have a very quick and easy way of seeing what the parent is concerned about. The other really nice thing about the Children's Sleep Habits Questionnaire is it screens not only for the insomnia, but for some of these medical conditions, so that as a parent, it's very hard to ask a parent or even the therapist to be able to say to their doctor, I'm worried about sleep apnea, but if there's specific questions on there that then they can bring to the physician or the therapist, or we can teach parents how to look at it and say, okay, these are the areas I circled for these particular questions related to snoring. If you scored a number greater than this, or you scored yes to any of these questions, bring this up with your healthcare provider, and that's, you know, a way that we can do that. So that's, I think that the long answer is, to Osmond's question, is you need to know your audience, and you need to do something that is going to work, because if it's too complicated and it's not done, then you won't have any utility. You know, you won't get sleep on the radar at all. Does that answer what you were? Okay, great. Other questions? Yes.
Do you think that pediatricians are starting to become more aware of and trained in issues related to kids on the spectrum, so that when parents go to see them and talk, you know, when the kids are really young and you don't know what the problem is and the kid is not sleeping, that this is something that will now occur to them? Maybe this is what's going on.
Yeah.
More awareness now?
I do. I think that, you know, the question was how aware, or are pediatricians and other healthcare providers being more aware of autism? I think absolutely yes. I think one of the good things that's come out of the increased prevalence of autism, regardless of why it's more prevalent, and we're still trying to figure that out, it's when my child was born in 1998, when my oldest son was born, it was 1 in 150. And now it's 1 in 68. So it's really become quite prevalent. And even, I think, Deborah, when your son was born, it was probably, 1 in 750 or something like that. So it's really increased. And because of that, it's talked more, it's more in the media, continuing medical education, which all of the providers have to do, or you know, is stressing it. And it's just one of those, if you see it and then you are familiar, then you see another child. In fact, that's one of the concerns is making sure we don't overdiagnose, because now it's so prevalent and people are seeing it and people are talking about it. And I think it's good, because people are more aware. It makes it more able to get resources. Parents are getting help when it used to be, you know, people didn't understand it. So I think, yeah, I think with increased prevalence, one of the good things that comes is an increased awareness and recognition. Yes?
Has there been any studies done in relation to, like, the chronic stress that these kids experience during the day and the lingering effects on it for the sleep disturbances? Like, has there been any correlation between that? Because I know, like, all the kids that I go and interact with, they experience significant stress, like, throughout the day because of their sensory integration differences and, you know, their communication differences as well. I'm just curious as to how that impacts on what happens at night.
Yeah. It really is a chicken and an egg question. You know, the increased stress, how does that impact sleep? How does sleep impact stress? And one model that we're exploring, because I'm both a clinician and a researcher as well as a parent, one model that ties it together really nicely is cortisol. Cortisol is a stress hormone. And what they're finding is, normally when we wake up, our cortisol level is at its highest, or shortly after we wake up. And then over the course of the day, it goes down. And ideally, before we go to sleep, it's its lowest. What we're finding in kids with autism is that in some kids it's blunted, so that their cortisol does not go from being high during the day when you need it to be high because you're stimulated and you're doing all these things and you need to interact with the world. It's actually not going down at night when you need to be able to go to sleep. And this is this being overstimulated, feeling like my brain can't shut down, which a lot of kids can articulate to me as one of the problems with it's not so much that they're anxious at night, and a lot of kids are anxious, so I don't want to discard or downplay being anxious, but it's more of a like just feeling like they can't turn their brain off at night. The parents are like, I can't find the on-off switch. So, and we think that might be this cortisol issue, so that their cortisol is not modulating. But the interesting thing is then if you go to bed or you go to sleep with high cortisol, you're going to potentially have disrupted sleep at night because your cortisol hasn't come down, right? So the increased stressors during the day are adding into making your sleep more disruptive because you're not able to turn off your brain. And then because you're not able to turn off your brain at night and your sleep is disrupted and restless, and a lot of parents will say to me, my child gets the normal number of hours of sleep, but they're restless. Then when they wake up, they haven't had, what I brought up, the restorative theory of sleep, they haven't had a chance to normalize their cortisol, so they start out with higher levels of cortisol, and they're not ready to recharge. They're not getting that recharge for the day. So they start up high, and then the whole vicious circle starts again. And the way and again, that's a theory. We're still having to do more work with cortisol. We want to know if cortisol is abnormally high in the kids with autism who don't sleep.
Yeah.
It requires more study, but that's one way to think about it. And then when you think about treatment, one of the things that I advocate is not just the behavioral therapy, but sometimes we'll use melatonin in these kids. And melatonin has it actually can calm the brain down and help there. So the idea of the two together, the soothing bedtime routine and the melatonin, might be abolishing that feeling like I can't shut my brain down, allowing the child to calm down, and then they can move forward and hopefully sleep well, and then start out the day less aroused, have more tolerance or resilience for the stressors and the sensory issues that come up during the day. So that's where we're going with that. Yes?
So, say you come from a family with multiple kids, and you interact with the other kids, do you think, even though you're not directly talking towards, say, the one child with autism, when you're interacting with your other kids, do you think that would overstimulate that, say, even if it's not even directly related to them?
Right. So the question is, what about multiple kids? And you're right. I mean, I think the concern would be when you're working with the other kids, particularly around bedtime issues, that could stimulate the child with autism. What we oftentimes will do is we'll teach the family strategies, and you'll hear about them this afternoon, that not only work for one child, but work for other children, including those who might not have autism. So the strategies I'm going to teach you or show you or model actually work for all children. And some parents have said to us, it's actually worked as well for my other kids as my child with autism. What's unique about them, though, is they were developed and are specifically structured to get at the challenges that kids with autism face, as well as their strengths. So, for example, the bedtime routine is very structured. And kids with autism love that. Many kids with autism love that. They love the structure and they love the predictability. But what we found is we've been most successful when we haven't necessarily tailored the intervention just to the child with autism, but to all the kids, and figured out and worked with the family to say, okay, if we pick Johnny's bedtime, Johnny has autism, if we pick Johnny's bedtime to be 9:30 because he needs to be up a little bit later, to have that time to wind down. What are we going to do about his sister and his other brother, and how are we going to, make sure they don't feel like they're having to go to bed earlier and he's able to stay up? We just kind of have to put something together for the whole family. That's a really good point. Yes?
I would like to know, what would you suggest is the quantification of the amount of hours sleep per night or nap times during the day? One is the case.
I knew that was going to come up. The question is how much time should, what are the magic numbers? And it's really interesting. There's a story behind that, which is when we put this book together, we were specifically asked by the editors. They said, you really have to put a time in here, and it's somewhere in here, but we were very resistant to it. We just didn't really want to put in how much time the child needed, because if you read the books, they're written for children who are typically developing, and the idea is it's supposed to, and don't write this down because I don't like to quote a time, it's supposed to be 9 to 11 hours for school age and 11 to 13 hours for preschool. The problem with that is we don't really know how much sleep an individual child needs, particularly a child with autism. And I've seen kids with autism only need 8 hours. And the problem is need, we don't know what need means. The studies, it's sort of like the cortisol, the studies haven't been done yet. I suspect that there are kids with autism who don't need as much sleep. We don't know that. We have to test it. But the concern is, the biggest concern is if you follow the books and you try to get the parent to get their child to sleep 11 to 13 hours, because that's what the book says for typically developing, they put them to bed too early, because let's say you have to get up at 7 o'clock or 8 a.m. for preschool, then to get the 11 to 13 hours, they have to go to bed 11 to 13 hours before that, and they may not be ready to go to bed at that time. So they lie awake, just like any of us. You lie awake, you're not really tired, you're not going to bed at your natural bedtime. It's similar to jet lag, let's say, for example. And then you're trying to fall asleep and you can't, and you fidget, and you're restless and you're anxious. And the kids with autism who have a tendency to be restless and anxious are just going to be more worked up. So what we finally compromised that we would do in these books is say, this is what's recommended for typically developing children, but everybody's different. Children with autism may need less sleep. We don't know that for sure. But what we do know is that if you try to go to bed too early, and you can use yourself as an example, you're not going to get the same amount of sleep that you normally would. You're going to be more fidgety, you're going to be more anxious, and you might actually end up going to bed later and losing more sleep than if you would if you picked a later bedtime to begin with. And we're going to talk more about that this afternoon when we talk about the forbidden zone and the child's natural bedtime, and I have a slide on that we'll go through. So the short answer is, the books are all well and good, but we don't really know how much sleep a child with autism needs, and everybody's different. I mean, you can go back to adults as well. There's such a thing as short sleepers, where some of us need 8 hours, otherwise we just can't function the next day. Some of us need 6 hours, and I've always been really jealous of the people who only needed 6 hours because they could get so much more done. But Thomas Edison was apparently one of those people who only needed 4, 5, 6 hours of sleep, and that may be why he invented the light bulb, because he was so bored, But we're still trying to figure that out for autism. Yes?
Can you comment on the increasing use of technology and screen time and how that's come into your research?
Yeah, so screen time is a really interesting subject. In fact, there was a paper recently looking at screen time in autism and seeing that kids with autism who used computers or iPads, tablets, whatever, had less sleep, total sleep, which isn't earth-shattering, but is a very important point that was made. I mean, I think we all would have predicted that. And it is a problem, and it's a problem for two reasons. One is the the screen things can be very stimulating. They can be stimulating video games, for example. The second thing is the light can be very stimulating, can actually suppress our natural melatonin levels. And I don't know if any of you have had this experience. I certainly have, where I'm like checking emails late at night. Deborah knows I do this. It's really bad. And I'll be checking emails, and I'll be on my computer. I'll be working on a talk or whatever. And I feel fine. I know I'm supposed to get to bed at 10 o'clock because my son's, going to be up for school at 6 for the bus. But, it's 9:30, 9:45, and I feel great. And then around 10:15, I realize I probably need to go to sleep, and my husband's like, when are we going to go to bed? And I sit up from my computer, and I'm like, whoa, I'm wiped out. But I didn't realize I was wiped out when I was sitting at my computer because the light was so stimulating, and I was so engaged in my video task, whatever I was doing, whether it was putting a talk together or answering emails. So there definitely is this effect of light on us, and it's the same light that helps us acclimate when we go to a new time zone, but it can be very stimulating when it comes in the form of videos. Now there is screen time. There's this concept of blue light that I haven't worked with much yet, but I'm really excited to do more with it, where you can actually, there's certain types of light that are more stimulating than others, and you can actually put covers and screens on the screens to block out this particular kind of light. As I said, I don't have a lot of experience with it, but that may be one way that we can decrease it. But I think the best strategy is, and you'll hear more about this afternoon, is to try to limit the screen time, or if you can't limit it, move it earlier in the day so that it's not there at least 30 minutes, ideally an hour before bedtime. Yes?
What color would be less stimulating
Then the blue light, light is a whole spectrum, so it's like a rainbow, right? So if you can cut out this blue light, and I have to look up which frequency it is, but it's a specific frequency of spectrum of light, you can potentially not have the same problem. The other place you'll read about it or hear about it is shift workers. When they're driving home in the morning, they've been on shift, they want to go home, they want to be able to go to sleep when they get home, but if they drive home and it's bright sunlight, that can interfere with their ability to go to sleep when they get home because it messes up their natural melatonin levels. But they can wear these blue blocking sunglasses that allow them to drive safely because the other light comes through, but it blocks the light that is particularly stimulating. Yes?
I've recommended that to some families, and I do find some families mention that using the iPad or watching TV before going to sleep actually helps some children fall asleep.
Right, that's a really good point. Some people do find that using the iPad or watching the TV helps, and this is always an interesting thing. I really do try to limit the light if I can. One of the nice things on some of these tablets, like the Kindles and others, is you can adjust, and even on the iPads, you can adjust the light level. So if the child does need a book or something, I will sometimes allow that or recommend that. And flexibility is so important. Sometimes kids like to hear some music before they go to bed, and I'm okay with that, or the noise from the television. I'm okay with that. We'll talk more this afternoon. The two things you have to watch out for are dependence on it, so that if it shuts off, they're not going to wake up because they don't have it anymore, and we'll talk about that this afternoon in more detail with the thing that you need most when you wake up is the thing that you had last before you went to bed, and then also making sure that it's just not stimulating and interfering. What we're going to do in the next session is discuss how to partner effectively, how families can partner effectively to address medical concerns that impact sleep and also use medications. So I'm going to use an example. This was believe it or not, Osmond's case from earlier that I've distilled into one slide. I've named the young gentleman Scott, and he's 16. He's a young man, and he's had sleep difficulties since birth, most prominently sleep onset delay, meaning difficulty falling asleep. And as we heard earlier, he was diagnosed with attention deficit hyperactivity disorder, major depressive disorder, oppositional defiant disorder, as well as autism spectrum disorder. And he was treated with 7 psychotropic medications between the ages of 2 and 16 years with no success. And in fact, he had significant medication side effects that were seen with all of his therapies, including obesity and obstructive sleep apnea, from the weight gain that goes along with these medications, and then apnea. You could be more prone if you're overweight. And then he was eventually diagnosed with restless leg syndrome, which we'll hear about, treated with iron as well as the medication gabapentin, which is used for sleep and restless legs. And this led to an improvement not only in his sleep onset delay, but in some of his behavioral symptoms as well. And the point that Osmond was making earlier is that it's very, very common for children and young adults on the autism spectrum to be medicated, over-medicated. So one medicine doesn't work, they're put on another, they're put on still another, and this is true. People will come to me, patients will come to me, families will come to me, and they're on melatonin and clonidine and Klonopin and trazodone and Tenex, and they're on everything. I mean, they're on like all these medicines all at once, and sometimes at very high doses. And the child is still not sleeping, and they've developed all these side effects. And sometimes the very first thing I try to do is to start whittling away at some of the medicines. And also looking, as was the case in Scott, for some other condition that may be disrupting the sleep that's more medically based and isn't necessarily, you want to really know, like if it's restless legs, you want to target your therapy toward that. If it's sleep apnea, you want to target your therapy toward that, rather than just adding on layer after layer of medication use. So I mentioned this earlier, the causes of insomnia, and what I want to focus in this part of the talk on are the medical, neurological, and other sleep disorders categories, and talk about each of these in a little bit more detail. So we developed a screening list within the Autism Treatment Network, and we've published it, my colleague Ann Reynolds and I from the University of Colorado, Denver, in sleep medicine clinics, looking at GI problems, seizures, pain, sleep disorders, psychiatric behavioral conditions, and also reviewing medications. And it looks like this, and it's something that the pediatrician can do very quickly, or the healthcare provider can do fairly quickly. And again, what helps is the parent can fill it out and bring it to the visit. So what the healthcare provider is doing, just like with the Children's Sleep Habits Questionnaire, is scanning it quickly and seeing if there are any yeses that need to be addressed. So does your child have a history of reflux? Does your child have constipation, abdominal pain, seizures, unusual events during the night? So this way, even if the parent doesn't know if the child is having a seizure, they could be asked about unusual events and then asked, is the event similar every time, which suggests a seizure because it's the same pathways in the brain firing. Does your child snore loudly? Does your child gasp for breath? Allergies, coughing at night, pain, dental pain, tooth pain, eczema, sensitivity to light. How much meat are they eating? Do they take a multivitamin with iron, which gets at the restless legs, which can go with iron deficiency, restless sleep, leg pains, growing pains, which can be symptoms of restless legs. So again, this is a quick and easy way for the family to partner with the healthcare provider to identify what the parent can provide, and then the healthcare provider can follow up. And then there are sleep disorders apart from insomnia, but which can contribute to insomnia. So we're going to talk about these in a little bit more detail: sleep apnea, restless legs, seizures. Starting with sleep apnea, I mentioned earlier, it's not necessarily more common in children with autism, but it is really common in the general population. It's estimated to be about 2 to 6% of typically developing children, and it's important to treat, particularly, well, in any child, but in autism, it may be contributing to some of the daytime symptoms. And the theory now, or the feeling now, is if you see a child with attention deficit symptoms who's typically developing, you always want to ask about sleep, and particularly sleep apnea, because they're very highly related. And similarly, a child with apnea may manifest their daytime sleep problems or their nighttime sleep problems as hyperactivity during the day. Many times as adults, when we're sleepy during the day if we haven't slept well at night. It comes out as sleepiness during the day. But in kids, it comes out less as sleepiness during the day and more as hyperactivity. It's almost like the child is trying to compensate and be more revved up for their lack of sleep. And what happens in apnea is when we're awake, we're able to breathe normally, we're able to control our airways, but when we go to sleep, everything relaxes, the tongue falls back, the muscles relax, and we stop breathing, and it's repetitive. So you'll stop breathing, you'll wake yourself up to breathe, you'll tighten your muscles, and then you'll go right back to sleep, and the cycle will start again. In kids, the tonsils and adenoids are oftentimes the culprits. Here's the tonsils, and they could even, when they're enlarged, they could even be kissing, meaning they come together and meet in the middle. The adenoids you can't necessarily see by opening up the mouth and looking, but they're in the back, and an ENT can see them, or you can see them on a lateral X-ray. And this is oftentimes one of the biggest causes of sleep apnea in children is overgrowth of the adenoids and tonsils. Obesity can also be a cause. We're right now in the middle of an obesity epidemic, particularly in the States with the sedentary behavior and all, and poor diets. Allergic rhinitis, go back, can contribute. Craniofacial abnormalities, this comes into play less in autism and more in, let's say, Down syndrome or other neurodevelopmental disorders, some of which can have features consistent with autism. And then neuromuscular or hypotonia, which is also common in Down syndrome, can contribute. Usually there's multiple factors. Oftentimes there's a family history, so I'll always ask about whether, not just whether dad or mom have sleep apnea, but whether dad or mom are loud snorers, because sometimes we won't diagnose sleep apnea in the parent. We'll find out about it in the child first, and then we'll end up diagnosing the parent later, which is one of the fun things about doing family medicine sleep. I see all patients across the lifespan. These are some of the facial features that can contribute to sleep apnea. Small jaw can contribute, cleft palate. And the nocturnal symptoms include loud, continuous, nightly snoring, apneic pauses, paradoxical movement where the chest and the belly are moving opposite, restless sleep, sweating in sleep, abnormal sleep positions. Sometimes kids have been described to sleep on all fours with their head up to try to open up their airway. And they do that naturally, and it's something they've learned to do. Mouth breathing during the day, chronic nasal congestion, hyponasal speech, difficulty swallowing, morning headaches, frequent infections, or poor appetite. And then during the day, we may also see excessive daytime sleepiness, which manifests as difficulty waking up for school, falling asleep at inappropriate times, including during therapy sessions, increased naps. But then we may, instead of seeing the excessive daytime sleepiness, as I mentioned a few minutes ago, see more acting out, mood changes, inattention, ADHD, as well as academic problems. And then other associated features can be bedwetting, enuresis, growth failure, and then increase in partial arousal parasomnias. I'm going to get to parasomnias in a minute. This is sleepwalking, night terrors. You can actually have an increase in these abnormal movements during sleep if you're having apnea, because apnea can kind of disrupt your sleep and make it more likely to have these. And then an increase in seizure frequency has also been described in sleep apnea. So the treatment options, the first line treatment is adenotonsillectomy, removing the adenoids in the tonsils. If this does not work, we sometimes use CPAP, which is continuous positive airway pressure. And this involves using a machine that delivers pressurized air through a mask into the upper airway to splint open the airway and keep the airway open. And as you can imagine, it's challenging in any child, particularly a child with autism who may have sensory issues. And it's really interesting. I've had several kids with autism as well as several young adults tell me that they did okay with the mask, but what really bothered them was the machine. The noise of the machine really bothered them, even though it's not that loud. Over the years, the technology has really improved to where it's almost more of a white noise sensation, but they really couldn't stand having any sort of unusual noise. So that was really interesting to me, but the sensory issues really do come up. We do work with kids, young adults, to desensitize them, meaning we'll prescribe a mask and let them take it home, wear it watching TV or a video where they can kind of get used to it. They can wear it 10 minutes and then the next day 15 minutes and gradually increase use, and then eventually wear it with sleep. And this is where therapists can really make a big difference. So that's the treatment there. There's some other treatments, including jaw surgery. There's some orthodontic treatments that have been developed for sleep apnea in the general population that may be effective as well. But the bottom line is I wanted it to be on your radar because it is really common. It does affect behavior. It also has health issues, and it's something we don't want to miss. The way we diagnose sleep apnea is through an overnight sleep study or polysomnography, because just getting a report of snoring or noisy breathing is oftentimes not enough. Sometimes I'll have a report of snoring, noisy breathing, even pauses in breathing. I'll do a sleep study. The sleep study will be normal. I'll call up the mom or dad with some trepidation because I feel like they're going to say to me, "What do you mean the sleep study was normal? My child is stopping breathing." And then they'll say to me, "Oh, that's great. I'm so relieved. I'm so reassured." I'm like, "Well, I thought they were snoring and stopping breathing." "Oh, they were, but I think it was because Johnny had a cold that week or whatever." So, it's really important. We don't want to subject kids to having their tonsils come out and have surgery if they don't really need it. And sometimes we've found that the symptoms can be very transient. The flip side can also happen. It can be very subtle. It can be the parent may not know that their child is pausing or stopping breathing. They may just hear some noisy breathing, but the child is waking up at night, and it's enough for me to say, the child is waking up. I don't know for sure what's going on here. Dad is a snorer. I want to be absolutely sure. I'll do the study, and sure enough, they'll have sleep apnea, and it could even be pretty severe. So there is not a great correlation, even in typically developing kids, between the symptoms of snoring and noisy breathing and what we find on the sleep study. And it's actually even harder in kids with autism because, at least in typically developing kids, we oftentimes will have evidence that they're having some behavioral problem during the day, inattention, hyperactivity, irritability. In kids with autism, they may be having those daytime problems because of their autism. So it's hard to really know if they're, it's hard to really figure out based on their nocturnal symptoms whether we're dealing with sleep apnea or not without doing a sleep study. So what do we do in a sleep study? First of all, we measure sleep, but one of the questions I get is is it really valid to measure my child's sleep when they come into a lab and they have all these wires on them and they're all hooked up and they're in a strange, unusual place? And the answer is no, it's not going to be normal sleep. What we're really interested in is not capturing their normal sleep, but whether something is happening in their sleep that is amiss, that isn't correct. So we may not see this beautiful sleep we call it sleep architecture, which is a diagram of, as the night goes on, what's happening to their sleep stages. Normally we enter sleep through non-REM, 1, 2, 3, 4, and then about 90 minutes after sleep onset, we hit our first REM period. Infants actually enter sleep through REM. Over the course of the night, we have more and more of the REM sleep and less of the non-REM sleep. We'll actually come back to this when we talk about these night terrors and sleepwalking. Those are disorders that oftentimes come out of the first part of the night and out of deep sleep, which is most prominent in the first part of the night. This is how we can tell what stage of sleep a child is in based on the EEG. This is the awake EEG. You can see kind of densely packed waves. Stage 1 looks similar. Stage 2, we start seeing features. They call them either K-complexes or sleep spindles that are either these really high waves or more close together packed waves. And then stage 3 and 4, which we're now calling N3 sleep or deep sleep, is these high slow waves that we see throughout those stages. And then REM sleep, rapid eye movement sleep, is when most of us dream, and we also can have nightmares out of REM sleep. During REM sleep, the EEG looks similar to during light sleep or stage 1 sleep, but we also can monitor eye movements, and we can monitor chin tone. And if the chin tone goes really low, that's a symptom that we're in REM sleep. And if the eyes start moving around really quickly, that's a symptom that we're in REM sleep. So we can use the whole eye leads, chin leads, EEG to help figure out what stage of sleep we're in. And then this is another example of a hypnogram or a graph of what somebody's sleep looks like. And you could see it took this child like 2 hours or even longer to fall asleep. So that's a good example of sleep onset delay in a child with autism. So how do we do a sleep study in a child with autism? It's not easy, but everybody's different. Some children do really well. Some children have a lot of challenges. The children who tend to do really well are the ones who are really excited about the computers and the technology, and they're really fascinated by all of the different medical equipment, and we can show them and work with them, and I'll oftentimes show them their sleep study when it's over and review it with them, and they really like it. And these are, you know, our future engineers, of course. The children who have more difficulty and who have more tactile sensitivities, or who are minimally verbal, who have trouble with being in a new place, we oftentimes will pull out the iPad and have them play a comforting video or a game while we're hooking them up, which is the term that our techs use for putting all of these sensors on. We try to call them sensors and not electrodes, because electrode is a scary term. You know, we don't want parents or children to think we're going to be putting any electricity into them. We're simply monitoring what's there. We oftentimes will look at this paper and use the wording in it. It talks about making polysomnography more child-friendly for any child, regardless of disability, using words like sensor, using basically saying we're going to put, you know, some jewelry, hair jewelry if it's a girl. We're going to be putting different sensors that light up and glow on your fingers. That's the oxygen monitor. Different ways to talk to a child about what's going to happen, talk to a family about what's going to happen. We also do our studies in a hotel, which really helps. The parent can sleep in a bed adjacent to the child. And we also oftentimes will put the sensors on after the child falls asleep. We'll just very gently put them on. We don't always get them all on, Sometimes we have to only put a few on, but we oftentimes get enough to at least be able to diagnose what we need to diagnose. And in this case, we're looking at sleep apnea. We're looking at the airflow is here, and then it flattens out. So it's flattening out here and then picking back up. And then it's flattening out here and picking back up. And you could see these arousals in the EEG here, 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 and here. You can also see the oxygen drops after the event. It's hard to make that out with these numbers, but the oxygen level is dropping. And there's also some leg kicks. Now, the leg kicks are interesting if they're associated with a breathing problem and you breathe, so you stop breathing and then you breathe again, and that's the blockage of the airway being relieved, and you kick your legs, that's part and parcel of the whole arousal and the whole apnea. But sometimes we see these leg kicks without apnea, and that's part of what we call periodic limb movements of sleep, or which can go with restless legs. And it's a little confusing because the two go together. Sometimes we'll see restless legs without periodic leg movements of sleep. Sometimes we'll see periodic leg movements of sleep without restless legs, but they oftentimes go together. And the reason I bring that up is because diagnosing restless leg syndrome, particularly in a child, let alone a child with autism, has a lot of challenges. And Osmond is very involved in the international committee that's coming up with these definitions. So restless legs consists of a funny feeling in the legs, bugs, worms. The best description actually an adult patient ever gave me was feeling like there were these bugs crawling and they were going up and down his veins. It's like gnawing. It's not necessarily painful. It's very uncomfortable. And it's also accompanied by an urge to move the legs. It's improved by movement. It's worse at rest at night. But if you can imagine, it's really hard for any child, let alone a child with autism, to describe this. I had one child in a study that we were doing, maybe 1 out of 20 children was able to actually articulate this to me, and then he was not able to tell me if he felt better or worse over the course of the treatment, which was an iron study. It is hard, and that's why I think having a family history, it oftentimes runs in families, so getting that family history of similar feelings in the parent who can tell you what's going on, doing the sleep study and seeing these leg kicks, not associated with apnea, but they're on their own, getting an iron level, and it's actually not an iron level, it's a ferritin level. Ferritin is basically, think of it as iron stores. So it's like you have money in your pocket and money in the bank. You have iron that's freely circulating, and then you have ferritin, which is a measure of how much stores of iron you have. And the other tricky thing is, so many times when I tell parents to get a ferritin level, the pediatrician will order an iron level by mistake. So you want to be sure it's a ferritin level, and I'll write that out on my card, ferritin level. But then we also want to make sure it's not where the level comes back normal and we're done. The normal range in many labs is 20 or above, but people have shown in adults, and they're finding similar work in children as well, that if it's 20 to 50, that's considered normal but low normal, and you could still have restless leg symptoms. So we tend to treat above 50 if the child is having restless sleep, or lots of leg kicks. And the treatment, the first thing is to supplement the iron if it's low. So if the ferritin level is low, you would give an iron supplement. Oftentimes the multivitamins with iron don't have enough iron in them, so you want to actually give supplemental iron. And then the other is some medications actually can help restless legs, including gabapentin, clonazepam, some of the ropinirole, some of the medicines we use for Parkinson's disease actually have helped restless legs. And this is just an example of a rating scale we put together for one of our studies where we had the child try to tell us if their legs felt achy or felt weird or felt jumpy, and whether they hurt or had bugs crawling or pinpricks. And also we did them like the smiley face. We call this a Likert scale, where on a scale of 1 to 5, they were able to tell us how badly their legs bothered them. And this was all well and good. We had a great time developing this scale, but we couldn't find it to be that useful because at least the kids in our study, it might work better with young adults, I don't know, but the kids in our study really had a hard time telling us what was going on. They were 4 to 10-year-olds. And that's why I think monitoring iron level or ferritin level, getting a family history is so important.
So if there's a family history in regards to it, should it just be sort of an automatic, go get the blood test done anyways, just to see, just to rule that out?
Right, so if there's a family, okay, so if it's a child with autism who isn't sleeping well, who's got restless sleep, who's waking up at night, who maybe having trouble falling asleep, but they're not able to tell you, and there's a family history of restless legs, I would likely get a ferritin level in that child and make sure that they don't have a low ferritin level. If their ferritin level is normal, it's trickier because they still could have restless legs and not necessarily have inherited the low ferritin, because there are, you can have a family history of restless legs. It usually goes with having a low ferritin, but not always. So I would, that would be a little bit more tricky. What I might do in that particular child, if I really suspected and I couldn't find any other reason why they were having sleep problems and I did my behavioral interventions, is I might actually consider treatment with one of the medications that helps insomnia and also helps restless legs. That's a great question. In terms of some of these other uses of the EEG, sometimes we'll combine the sleep study with an EEG. We call it EEG polysomnography, to try to detect seizures, sleep terrors, also called night terrors, sleepwalking, head banging. And I want to make a pitch here. When we try to bring families into the lab and bring kids into the lab and we want something to happen, it won't, even if it's happening every night. There's something about being in an unusual, a different place that somehow suppresses these events. So I really encourage the families, especially now with cell phones being so prevalent, to try to capture what their child is doing on their cell phone and bring it to the clinic visit. And this has been enormously helpful because oftentimes you want to not just see one, you want to see 3 or 4 of them, because you can see if they're similar. If they're similar, it makes you worry about seizures, particularly if there's some stereotype movements. And that's what I'm going to get to next, is I want to describe what these are and show you some examples. So let me pull up my videos. So the first one is an example of sleepwalking, and this is actually something I brought with me from the University of Michigan because it's such a classic example. Let's see, opening, okay, there we go. And what you see in this video, this little girl is going to make multiple attempts to get out of bed, and she finally is going to be successful. And then if you look here at the EEG, there's high waves. It's a lot of dark lines, but there's a lot of like high waves with a lot of space between them. And that means she's still asleep. So even though her eyes are open and she's getting out of bed and going back into bed and rearranging the covers, she's actually still asleep here because the EEG is showing sleep activity. And what you're going to watch her do in a moment is get out of bed. She finally makes it. And then she kind of does something that the sleep techs I show this to find incredibly funny. She starts destroying the evidence. She starts unplugging the box that her wires are coming from. And she does it pretty vigorously.
Mama, what are you doing? Nothing. You just unplugged all those wires. Yeah, no. Why'd you unplug them? Why?
So she at least isn't admitting why, but anyway, she wakes up somewhere in there. We're not sure where because she took off all the wires, but, and then seizures are really interesting. I want to show you two examples of seizures, and I want you to see how similar the seizure is. This is the first example. This is a young woman with frontal lobe epilepsy, and watch her left arm, which is under the bed sheets, extend. You can see that right here. And now it's lifting up, it's out of the bed sheet, and it's coming over her head. Her right arm is extended out. It's like, we call this a fencing position. And what's happening is the video is showing you the event, the EEG is showing you the seizure activity. And then I have a second event in the same young woman that was taken from the same night. She had like 11 of them in one night. And you can see how similar it is. Here the bed sheet isn't covering her arm. It's the same thing. One of the arms is flexing over her head. The other arm is extending. And she has these jerks. And this is a seizure because it's the same parts of the brain are firing every time. And there's clonic activity, there's the stiffening. So even without the EEG, that would be highly suspicious of a seizure. And that's something we can record in the lab. There's also something that parents can record on their phones, and then we can decide if we need to bring the child in for a sleep study with a full head EEG. This is an example of another type of epilepsy called benign Rolandic epilepsy. And the benign part is they oftentimes outgrow it. The Rolandic is it refers to the part of the brain that controls movement of the face and motor areas, and you can hear it as well as see it. You see that movement of his mouth. And they're very short, and we were lucky enough to capture it. He had actually come in for rule out sleep apnea, and he had one of his typical seizures while he was here. And then the other things that can happen besides seizures, and just to say, so seizures are epileptic activity caused by disinhibition of the brain. It can occur in any part of the brain. The part of the brain that it's occurring in is how it manifests itself, although it can spread from one area to another. So just because you see somebody moving their arm doesn't mean it's starting in the part of the brain that controls arm movement. It could have started in a deeper part of the brain and moved to the part of the brain that controls arm movement. But we can put this all together. Oftentimes what we're doing as sleep specialists is just making the diagnosis of epilepsy, and then we refer to an epilepsy specialist for treatment, for better characterization. Yes?
Two questions. I think I know the answer.
Yeah.
To this one, but epilepsy is genetic, right? There's some genetic, I think that there's some.
Right. Epilepsy can be genetic. It doesn't have to be. In other words, there's oftentimes certain, like the benign Rolandic epilepsy that I just showed you is a genetic epilepsy syndrome where either it runs in, it's autosomal dominant either for the seizures themselves or else for the brainwave activity that accompanies it. But some forms of epilepsy may be de novo.
And could parents tell, like, could we tell if a child was doing some kind of behavior while they were sleeping? Could we tell if it was a seizure or if it was just some kind of movement thing?
Right. So the question is, how do you know it's a seizure or not a seizure? And again, what we ask for parents to do is just to make their healthcare provider aware there is some sort of recurrent event that's happening and to describe it as best as they can. And if they can, bring it in, bring in a video on their cell phone. as clinicians, what we're interested in is there something where it sounds like it's the same thing every time, where the parent describes, for example, the left arm is always flexed, or the child is making chewing movements of their mouth, or a clicking sound like I just showed you. Is the event occurring multiple times throughout the night as opposed to just being in the first part of the night, which might suggest what I'm going to show you next, which is the night, or what I showed you earlier, the sleepwalking, where it's happening in the first part of the night when we're seeing that deep sleep. So I don't ask the parents to know all of that. I just ask them to be cognizant that there is an event happening that isn't, it's unusually different than the child is just waking up and needing something. The child may look like they're asleep. The parents will say that the child is inconsolable. They'll be staring off. You know, something that just does not look like a normal awakening. Does that help? Okay. And then the other category where they can seem like not themselves is not just the seizure, but the sleepwalking that I showed you. And sleepwalking, night terrors or sleep terrors, and confusional arousals all kind of go together. And these are all in the first part of the night for the most part. They're in deep non-REM sleep, although sometimes they can be in lighter stages. The night terrors, which I'm about to show you, the child can be inconsolable, difficult to really arouse. It's a little blurry, but the reason I wanted to show you this is for the scream part, which is about to come up. It's like a blood-curdling, really disturbing scream. And that, you know, you might say, well, why isn't that just a night waking? What parents will say is they could not console their child. They didn't seem to be awake. They didn't seem to be interacting with them. Again, it's oftentimes the first part of the night, doesn't recur as the night goes on. And it's tricky. I saw a child in clinic Friday last week before I flew up here, and it was, at 11 o'clock every evening, they had this type of event almost every night. But then at 3 a.m., they had a separate event where the child got out of bed and walked to their parents' room and asked for things. So it's not unusual to have two different things going on in the same child. And the treatments can be very, very different. In this case, this really begs for me to make sure there's no underlying sleep disorder that's disrupting the child's sleep. I would oftentimes look for sleep apnea. I would try to make sure I wasn't worried about seizure. I would put on a full head EEG if I was concerned, so I could look at the EEG as well. I would also see if the parent could capture some videos that I can look at. The child coming and waking up the parent at 3 a.m., being fully awake, being coherent, is not as concerning. There still could have been something that woke up the child, like sleep apnea or whatnot, but it's a very different, a different set of considerations that I would have for wanting to investigate. The other one is the head banging, which can happen at any stage of sleep, and is often felt to be something the child is just doing, but is real and is not necessarily deliberate. Some children with autism or other developmental disabilities may actually headbang during the day when they're fully awake and coherent as a way of relieving stress, or it can be a sensory-seeking behavior. However, kids can also do this in their sleep and be unaware of it. It's very hard to treat with medication, and the treatment oftentimes that we've found to be most effective is to use a soft helmet, because we don't want there to be any injury to the head, and also the proprioceptive or the tactile input that the child can get from the helmet can sometimes help the head banging. But this is a very commonly seen and very, it's not always entirely benign because the child can hit their head against the headboard or hurt themselves in some way. So those are the videos I brought to give you just a few examples of what we sometimes see in the sleep lab, what we capture. Before I move away from the videos, does anybody have any questions about them? I could take a couple questions, yeah.
Sorry, so is the head banging also associated with sleep apnea, or, because during the day it may be a seeking behavior, but not necessarily at night?
Correct. So at night, the point I wanted to make is that children can have head banging and be totally asleep, and it can come out of any stage of sleep, and they could stay asleep during these. So we don't want to confuse these with sensory seeking type behavior.
I have a question.
Yes.
The sleepwalking, they don't necessarily get out of bed, and is it a tremendous amount of movement where their head is at the other side of the bed?
Right. So the sleepwalking, I tend to put on the spectrum with confusional arousals or sleep terrors. Sleepwalking, oftentimes, they'll stand up, they'll get out of bed, they can wander throughout the house, but on that same spectrum is just waking up and moving around the bed and acting confused. And probably the most important thing in those cases is to be aware of safety measures. Let me just show you before I go on to the safety measures slide. This is an example of something we might capture on the EEG. This is a 21-channel overnight EEG that goes with the sleep study. And you can see here, breaking up the background are these high waves that disrupt the background. And that is evidence of an epileptic seizure. And then the safety issues are probably the most important. And this holds not just for the episodes I talked about, the sleepwalking, the sleep terrors, the confusional arousals, possibility of seizures, but even for night wakings where the child is awake and alert. Use of gates, locking outdoor doors and windows, lighting of hallways, eliminating floor clutter, avoiding frequent rearrangement of furniture, blocking access to kitchen, bathrooms, mattresses on the floor, use of sleeping bag to reduce wanderings, and then also notification measures so the parent knows that the child is up. And it could be a sophisticated alarm system, but it could also be bells attached to the door. It doesn't have to be really expensive, but it's something that alerts the parents to the fact that their child is out of bed and make sure that they're safe. I want to move to this whole idea now of how do you monitor sleep besides polysomnography, because as we mentioned, not only does it work for every child, it can be difficult to come into a strange place and have all these wires put on you and you may be tactily sensitive. Is there anything we can do in the house in the naturalistic setting of the child to monitor their sleep? And this is more once you've ruled out these medical things. So in other words, if there's a concern about apnea, if there's a concern about seizures, if there's a concern about leg movements, you really do need to do the polysomnography at this time. I mean, there's research being done about home studies, particularly in adults, but we're not at that level yet in children, particularly for things like seizures and sleep apnea, that we really feel confident detecting those outside of a sleep lab. But let's say that it's a child who does not appear to be having breathing problems or does not appear to be having anything unusual in his sleep. Then I think it is reasonable to look at some other monitoring techniques. So the case I wanted to bring up is Alex, 6-year-old boy with autism. He awakens his parents at 3 a.m. on most nights, but he may also play quietly in his room. In fact, his parents, this is actually a true story, His parents can measure how long he has been awake by the number of Lego towers he constructs. So he, builds these towers. And he has restless sleep. His bed sheets are often tangled in the morning. Let's assume that we got a ferritin level and it was fine. His parents are exhausted. They're very overwhelmed. And Alex's teacher describes him as being hyperactive and disruptive in class. Is there a better way to measure Alex's night wakings than simply counting his Lego towers? And this is the concept of using actigraphy. Actigraphy is basically using activity meters, which are within watches or these little chips, to measure sleep and measure the sleep-wake cycle. And the idea is that when the child is awake, there's a black line indicating that the device is active. And then when they fall asleep, the black activity dissipates, and then it starts back up again when they wake up. And you can actually, based on either a diary or an event marker that's on the device itself that the child can push or the parent can push, you can time when the child is going to sleep. So in this example here, you can see this blue event marker, and then you can measure out that this took about an hour for the child to fall asleep. And in addition to the visuals, there's also data that's collected quantitatively as well as qualitatively. So you can get a printout of how long it took on each night for the child, what time the child's activity dissipated. And when you combine when the child first attempted to go to sleep, which the parents can mark with this blue marker, with when they actually went to sleep, you can calculate sleep onset. So that would be this time here. The second night, it took a little bit less time. The third night, they fell asleep right away, but then they had this night waking in here. This is a child with autism and repetitive behavior, as you can see by the fact that they like to keep pushing this button over and over. But they pushed it, you could still use kind of their last push to tell you when they first attempted to fall asleep. So that's actigraphy, and it can be very useful because you can get a measure of how long it takes them to fall asleep, how long they're asleep, whether they wake up. And you could do it every day, and you could do it in the comfort of their home. They just wear a watch. It's best if they wear the watch 24 hours. It's not always possible for the kids to do that, but if we could at least get a good hour of baseline before, and then in the morning, before sleeping in the morning, we can oftentimes get what we need. Occasionally, kids have tactile sensitivities to the watch, less so than with the sleep study equipment, but occasionally with the watch. And we actually pioneered a pocket watch placement where they could wear the watch in the pocket of a t-shirt and then just Velcro it in. It's a snug-fitting t-shirt. So even kids who have tactile sensitivities to wearing watches can successfully wear these devices. And they're made by a variety of manufacturers. So there's the ActiWatch made by Philips Respironics, and then there's an AMI device, and they all pretty much measure the same thing. So that's actigraphy, and we found this really successful in many ways. First of all, it can really reassure the family whose child is having restless sleep and they don't know if they're awake or they're not, or they're moving around, or what's going on after they leave the bedroom. And oftentimes we've been able to show that the child is pretty much staying asleep, which has been reassuring to the families. If they are having night wakings or having a lot of difficulty falling asleep, we can tell that as well without the parent having to have their own sleep disrupted to like time when their child actually falls asleep or try to figure out when they're waking up, particularly in older children who might not tell their parents that they're awake. So this can be very helpful. And then in terms of treatment, we can monitor it before and after treatment. So after we start behavioral techniques or we do a trial of a medication, we can repeat the actigraphy and figure out what's going on. And we can even use it as part of the behavioral technique to improve sleep. These this can tell us how well, for example, is the parent abiding to a consistent bedtime. You know, how consistent is the bedtime between nights? There's light monitors on some of these watches, so you can figure out, is the child turning off the lights before bedtime when they're supposed to? Or, you know, are they turning on the lights in the middle of the night? Or are they staying awake, reading with their iPad when they should be asleep? So it can be a really nice technique. Again, it doesn't replace the sleep study if you're worried about apnea or seizures or leg movements or sleepwalking, but it can be very helpful for monitoring sleep. And as you can imagine, if you're going to get several weeks, it's going to be more accurate than one night in the sleep lab away from home with an unfamiliar setting and all of these strange wires on. Okay, so now I'm going to turn to medication treatment for insomnia, because the reality is not every child is going to respond to behavioral techniques, or you know, even though we write best used after behavioral treatments have been tried unsuccessfully and in combination with behavioral therapies, there are families, like the family I gave you the example of earlier, who are too overwhelmed, who are not in a position that they can implement the behavioral. And the reality is we do use medications. We try to use them with these guidelines that I'm about to go over. And we, as quickly as possible, try to implement the behavioral techniques. But there are families in crisis who need this. And whenever possible, we try to use a medication that will treat a coexisting condition or a comorbidity. So if it's a child with epilepsy, I'll try to use a medication they're already using, maybe at a slightly higher dose, or I'll move it from the morning to the evening. If it's sedating, I might add an evening dose. And then if it's anxiety or mood disorder, I'll try to choose a medicine, oftentimes in conjunction with a psychiatrist to help. And that way you're treating two things rather than one. And the other point I should make here is there definitely is a role for using medications to treat comorbidities that affect sleep. So for example, if the child is anxious, I've even found that a stimulating antidepressant given in the morning can improve sleep at night, because the medicine is treating the anxiety, which is then helping the child fall asleep better if they're not anxious. So I think it's important to realize sometimes we use these medicines for the underlying condition, and that's totally appropriate. Sometimes we'll use a medicine for both. We'll use a medicine to treat an underlying condition and also help with sleep. And then a good example of that might be a sedating antidepressant given at night that would help both sleep and depression. We like to start at low doses, especially in children with developmental disorders, because they're less able to communicate adverse effects to us, and that they may not be able to communicate adverse effects at all. So we want to make sure we start low and go slow. And then it's worth mentioning that for primary insomnia, there are no Food and Drug Administration approved drugs. It's all what we call over-the-counter. We published on 107 kids with melatonin. This was the largest retrospective review, meaning going back and looking at what had been done clinically to date. And we published that in 2008. And we only had 3 out of 107 kids who had side effects. And the side effects consisted of grogginess, feeling kind of spacey in the morning, and increased bedwetting, which might not have actually have been, it might have been that they were sleeping more and they were only wetting their bed when they were asleep, and the melatonin was helping them sleep more. So we were really pleased with how melatonin did. And as I mentioned earlier, melatonin is generally safe. You just have to be sure the preparation you buy has melatonin in it and not something else, and that it's not going to interact with any other medicines, and that you're not going to miss a medical disorder. And then the other medicine I wanted to mention that we were very successful in using was gabapentin, which we published on last year in kids with autism who did not respond to melatonin for night waking. So they might have been falling asleep okay on melatonin, but then they were waking up. And what's nice about gabapentin, which is also called Neurontin, is that it actually has been shown to increase the deep sleep stage. N3 sleep is what we call it, deep sleep, delta sleep. And it also has very few side effects. It has more side effects than melatonin in that kids can get sometimes a paradoxical reaction where they get more irritable and have more trouble sleeping. We also sometimes see this with Benadryl. When we experienced this in our trial and we stopped it right away, the side effect went away too. And then the other neat thing about the gabapentin is that it's one of the medicines that's used for restless legs. So if we can't make a diagnosis of restless legs, we can consider using gabapentin to help both restless legs, periodic leg movements of sleep, and insomnia. I also wanted to mention there is an extended release preparation of melatonin that's under study. The challenge with melatonin, its half-life is really short, meaning how long it's in the system, and the duration of action has been said to be only about an hour. Now, with that said, sometimes all you need is to get the child to fall asleep, and then they're asleep all night. But many parents have been concerned that they'll give melatonin, their child will sleep for a few hours, but then they'll wake up. And that may be because melatonin is not necessarily treating the night wakings. It's only in the system long enough for the child to fall asleep. So you might be able to get the child to stay asleep because you're teaching them to fall asleep with the melatonin, you're doing your behavioral techniques. The behavioral techniques are reinforcing the calming activity and the hypnotic activity of the melatonin. But there are kids out there who are going to wake up, and the melatonin in its immediate release form, which is most of the melatonin that's available in North America, is not going to keep them asleep. One of the challenges with extended release or timed release melatonin, as with any extended release or time release PrEP, is the way that extended release or time release works is there has to be a coating around the medicine. It has to be an actual pill. You can't crush it. It's not liquid. You actually have to take this pill, and to get the time or extended release property of the pill. The challenge is that many of our kids with autism can't swallow pills because of their tactile sensitivities and other things. So we have not been able to successfully test or try out whether extended release melatonin works in these kids who have night wakings. There's a study underway in Israel. Well, actually, it's in this country. It's in the U.S. with a company from Israel called Pharmaceuticals, and they have a micro tablet, which is a very tiny preparation of melatonin. It's about 3 millimeters. It's about the size of a cake sprinkle, and it's easier for kids with autism to swallow. So it will be interesting to see if that has any utility over the immediate release melatonin in terms of night wakings. Other than that, the options are pretty much a grab bag. There's clonidine, there's mirtazapine, nioprasine, zolpidem, zalopram, rameltian, and risperidone. And none of these have been tested in definitive trials. Many of them have side effects, and many children, as I mentioned earlier, will come to my clinic on multiple of these agents. And it's tricky to try to figure out what to do. Oftentimes, what I end up doing is actually lowering the medication if I can, because what I'll see, and this will come to us in this afternoon when we discuss it, is children will be so over-medicated and so sedated that they've not learned how to fall asleep on their own. So they wake up, it's almost like they wake up a few hours later with a night waking because they've not learned to soothe themselves back to sleep. But while if they're on less medicine, they'll actually be sedated enough to be able to fall asleep with the behavioral techniques we teach them, and then they can get back to sleep on their own in the middle of the night. So oftentimes less is more, and what we'll do is we'll try to whittle away at some of these medicines over time to see if we can get a better effect. But what unfortunately, like Osmond's example, it's not unusual to see layering where a child is not sleeping, they get started on meds, then they get put on more meds, they get put on still more meds because they're hyperactive during the day from not sleeping, and the sleeping meds haven't helped them, and then they get put more on sleeping meds, and they end up, as the example he provided, with 7 different medicines that they're on. And then I'm just going to reinforce, and we'll talk about this afternoon, why we want to really think about educational behavioral interventions first, after excluding these medical contributors, these medication, medical, sleep difficulties, night terrors, sleep apnea. And it's because of the challenges understanding expectations about sleep, being there, and the challenges with transitions, emotional regulation, all being amenable to behavioral sleep education, the not being able to communicate adverse effects of medications, and finally that there's limited evidence for medications to treat insomnia and autism. However, if the behavioral approach does not appear feasible, or the intensity of symptoms has reached a crisis point for the family, we consider medications. So going back to the practice pathway I showed you earlier, hopefully you could see where things are starting to fit together. We do our screening, and then in terms of the treatment, oh good, so you can look at this in a bigger copy. Thank you, Deborah, for blowing that up. So the part that we've been talking about in the last few minutes has been this initiating and this middle section, looking for the medical contributors, the sleep apnea, the night terrors, the seizures, and then either having the pediatrician or other primary healthcare provider initiate evaluation and treatment, or making a referral. So in some cases, like a GI problem or eczema, the medical condition can be treated and solved at the level of the primary practitioner. In other ones, like epilepsy or sleep apnea, it oftentimes requires a referral to the subspecialist, like the neurology subspecialist or the sleep subspecialist. And then at the same time, we're doing the assessing if the family is able and willing to use the educational approach, initiating the sleep education program, which could be one of the toolkits that we've given you today, or something more intensive, which we'll talk about this afternoon. And then if the family is unwilling or unable to use the educational approach, if they're in a state of crisis, they're just not able to do the behavioral, we will then move on to consultation with the sleep specialist.
In regards to the melatonin levels and cortisol levels, is there possible to be messed up on your melatonin levels before sleep? Because we've given our child melatonin, but then it doesn't seem to drug them the next day. So we don't like to do that with them, yet he still doesn't maintain his sleep.
Yeah, so we're going to talk more about melatonin in the next session, but basically melatonin is felt to promote sleep. It's our natural substance that all of us make to promote sleep, and it also can be given, as you know, supplementally. The biggest challenge with melatonin, like any other sleep aid, is if you give too much, it can cause grogginess the next day, and then it can also interfere with the child. It's the right balance. You want to give enough to try to get the child to fall asleep on their own, so that they'll have that skill. If they wake up at night, they'll be able to go back to sleep. But you don't want to give so much that it just kind of knocks them out and then they can't. So we'll talk more about that. It was a great question.
Is melatonin effective for all kids?
Question is melatonin effective for all kids? And that is it's a really interesting question from different perspectives. I think that it's effective for many kids. I don't know that it's always tried in the best light because, as I'll talk about, there's all different brands and there's all different. Now, I'm trying to refresh my memory. In Canada, it's prescribed or is over the counter, like in the U.S. Okay, so because it's over the counter in the U.S., there are all sorts of brands of melatonin. There's even some that are mixed with Benadryl, believe it or not. It's not controlled. There's not, for example, anything that says how much is in it. You know, it's not like, you know, that one brand compared to another brand, 1 milligram of one is going to be 1 milligram of another, whatever. So that's one of the issues why it doesn't necessarily work for all children. The bigger reason, I think, and I'm going to try to impart to you today, is that it's not necessarily combined with behavioral sleep techniques. And when you combine it with the behavioral sleep techniques, it's a lot more effective. Because it's almost like what we've learned in depression, where if you treat someone with a pill, if you treat somebody with an antidepressant, they're not going to be they're not going to benefit as much as if they have both therapy and the antidepressant. So oftentimes medicine and behavioral are synergistic, and particularly with melatonin, because the emphasis on melatonin is oftentimes to relax the child and to kind of help them settle down. So having the melatonin paired with or coupled with activities that actually help them settle down can be very, very helpful. Because I've had people say, and you may be referring to this in your question, that they've given melatonin and then it's worn off, or it only works for an hour or two and then the child wakes up. And what we're interested in studying, based on what we've found in our clinical experience, is whether melatonin plus behavioral education may be more effective than melatonin alone or behavioral education alone. That's one of the most common questions I get asked about melatonin is it effective for everyone? The second question that comes up with melatonin all the time is, what are the problems? Like, why can't I just give it to my child? Why are you such a stickler, Dr. Malow, that it should be monitored by a healthcare provider? And the reason I do is not because it's not safe, but because we don't want to we don't want to miss a medical condition that may be contributing to poor sleep in the child by just giving the melatonin and hoping it will help. We want to make sure the child has been evaluated properly for sleep concerns. And this could be at the level of the pediatrician or the nurse practitioner. It doesn't have to be at the level of a sleep specialist. But that's number one, why we don't just give melatonin or ask parents to give it without consulting with a healthcare provider. The second reason is because melatonin can interact with some other medications, such as Coumadin, and other medications that the child may be using for medical conditions. So we want to be absolutely sure we're being safe. Okay, time for some more questions. Yes?
Yes, I would like to know what would you say is the big difference between night tremors and nightmares? Because my daughter, I would describe pretty much exactly with the boy that you showed us. She would wake up in tears and almost like shaking and trembling. I am able to calm her down, but sometimes in one night she would have 2 or 3 of it. She didn't have it every night, but I would say in a week just to be able to quantify maybe once a week. And then one night she'd be like that, and then the same night she would laugh.
Right. So I'm really glad you made that point. The difference between night terrors and nightmares, I'm really glad you emphasized that, because I should have brought up nightmares. So nightmares tend to occur during REM sleep, rapid eye movement sleep. When our dreams occur, they're scary dreams. Night terrors occur during the non-REM sleep. So if I go back, let me just find that slide for you. Let's see, view, slide sorter, outline, because this is important. This is a good question. I want to be sure that I make the distinction. And nightmares, the child is fully awake but scared. Night terrors, they may not be awake at all. They may be still asleep. Like, remember those high delta waves I showed you on that child on the video? So, here we go from current slide. Okay, so the nightmares are occurring out of REM sleep, which is here, 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 and here. And usually, most of the nightmares are going to occur when the REM sleep is the most, which is toward morning, which is also when we tend to remember our dreams, the dreams toward morning. In the night terrors and the sleep terrors, and the night terrors and sleep terrors are kind of used synonymously. And the sleepwalking, that's more in the first part of the night during this deep sleep. And in the nightmares, the child is fully awake but scared. The night terrors, they may look like they're awake, their eyes are open, they may be screaming inconsolably, but they don't remember it. They're amnestic for it. They're still asleep. So that's the difference between the two. Okay. Sure.
Is it possible to have your child to have seizures, say, at night, but be completely normal throughout the day, like you wouldn't even guess it? Or does it fall into the same thing? Would they have seizures during the day?
Right. There are forms of nocturnal or totally sleep-related epilepsy where the seizures can be limited completely to the night. And a good example of that is that benign Rolandic I showed you with the kid who was moving the side of his mouth. Some of the frontal lobe seizures, the young girl I showed you who put the arm over her head with the fencing position, she only had seizures in her sleep. So certain types of epilepsy are limited to sleep. And we don't exactly know why. It may be that the connections between the brain areas that promote sleep and epilepsy are more active in those. But certain types of epilepsy are only during sleep. So it can be very challenging because it might look like something else. It might look like another sleep-related event. The other thing that's hard about seizures in your sleep and making the diagnosis is during the day, if somebody has a seizure, people are around. During the night, you know, that by the time the parents are alerted, the child's seizure may be over. During the day, oftentimes you can describe a funny feeling that you have. Again, it might be hard for our kids with autism to describe it, but funny feeling in the stomach, butterflies in the stomach, whatever. When you're asleep and you're having a seizure out of sleep, you may miss that. So seizures during sleep are really hard. Oftentimes you want to take that extra step if you're suspicious to do the overnight study. The other thing I should mention, we will sometimes see on the overnight study, even if we don't capture a seizure, we'll see funny brain activity like the examples I showed you, that we call it interictal or in-between seizures, and it can be very helpful. Like this activity here might come out even if you don't have an actual seizure, and that could be diagnostic. Yes?
With melatonin, because our body produces some of it anyway, it's thought with kids with autism, they just produce less. If you then go and supplement that, is there any suggestion that our body would then in turn make less or compensate so that
Yeah.
over time you'd need more?
That's a really good question. Let me address both of those because there are some studies out there showing that melatonin levels in kids with autism are less than in kids who are typically developing, but it's not definitive. We actually just published a study in the last couple of months. It's in the Journal of Autism and Developmental Disorders if you're interested. And I'd be happy to send it to post on the ACT website, showing normal profiles of melatonin in 9 kids with autism who were participating in our melatonin study. What it was we drew their blood in our clinical research center using a catheter, so we only had to stick them once, and we did these overnight blood draws. And we did it before we treated them with supplemental melatonin, and then at each subsequent time. And we actually we thought we were going to find low levels. We did not find low levels. We found normal levels. We found that the timing of melatonin was normal, of their own melatonin. And we also found that when we gave them the supplemental melatonin, they metabolized it normally. And that was pretty remarkable for us because, as I said, there had been studies in the literature, mostly older, some using melatonin levels during the day, which don't necessarily equate with what's going on at night, some that used urinary levels of melatonin and had found deficiency. So we did not find a deficiency, making us wonder if there's other things going on. Maybe melatonin isn't treating a deficiency in these kids as much as it's treating like that hyperarousal, that cortisol that we talked about earlier. So that's point number 1. I think there's a lot more that has to be done before we say that kids with autism have a melatonin deficiency. Because at least in the small sample, we didn't find it. And these were kids who were actually being treated with melatonin, who were going to be treated with melatonin. We did the levels before they were treated, of course. The second point you make is certainly something that comes up a lot. If we do give melatonin to these kids, regardless of whether they have a deficiency or not, could it somehow interfere with their own production of melatonin? The company that I mentioned in Israel who's doing this extended release melatonin study did some careful studies, and they actually found that it did not interfere with it as best as they could tell. But I think more studies are needed. My sense of things is that while kids who are on melatonin do not generally need more or higher doses, we sometimes do see that over time it's not as effective. But I wonder if that's less about the melatonin and more about either they're moving into adolescence and they have different sleep challenges, or the behavioral is not being necessarily implemented to the same extent that it was in the beginning. So I think it's worthy of more study. I tend to keep kids on melatonin and not worry too much about that, because what I found over time is the kids you keep on the melatonin do better than the kids who've come off of the melatonin because their parents thought they needed to have a break for a week or two to try to, reinstate their levels, because I'm not sure we've really proven that they do need to have their levels reinstated. Yes?
Could you comment on certain developmental periods like puberty and how that can affect insomnia or cortisol levels or
Yeah, so the question is puberty and what role does that play? And that's actually a section in this new toolkit, which I'm really excited about, is it gets into, all the different changes. I think the biggest change that we see with puberty is actually gets back to melatonin. We see that as kids transition into puberty and adolescence, they tend to go to bed later. In fact, typically developing children, about 10 to 15%, can have something called delayed sleep phase syndrome, which is exactly what it sounds like. Your sleep phase, your time that you go to sleep and wake up, is shifted. It's delayed. And when I was growing up, I don't know about you guys, it was called being a teenager. It was going to bed late and waking up late. But now there's this biological reason for it, and people have actually shown that melatonin levels, and I'm talking about typically developing teenagers here, melatonin levels are actually later in those kids. So the amount of melatonin is normal, but they secrete it later in the night than you would expect, later in the evening than you would expect. Melatonin is the gatekeeper of sleep, or one of the gatekeepers. So the idea is that you have your melatonin release and then you fall asleep. And in these teenagers, what they found is they were secreting their melatonin later, and therefore they were more apt to have a later bedtime. The reality is probably a combination of both the biological as well as the behavioral, because in addition to the change with puberty and adolescence where our melatonin is secreted later and we tend to have a later bedtime, we also have all of the societal influences of staying up late, getting homework done, socializing with friends. One of the biggest challenges we see, not just in our kids with autism, but in our general, typically developing population, is this tendency to stay up late on the weekends. And then in the Monday morning, they have to get up for school, and they can't get up for school because they're used to not only going to bed at midnight or later on the weekends, but then sleeping in on Saturday or Sunday morning until noon or even later. So it's very hard to then readjust on Monday morning and get back into that routine. So that's all what we're learning from the typically developing literature. In autism, we really don't know what's going on. We suspect there may be a higher prevalence of the delayed sleep phase, but we don't know that for sure. My colleague Suzanne Goldman at Vanderbilt is conducting studies looking at cortisol, looking at melatonin, looking at actigraphy to try to get a feel for what adolescents with autism are doing, whether they're good sleepers or poor sleepers, and seeing if we see any differences. But we haven't really sorted through the data there yet. Yes?
Children with these events that you have up on the slide now, is it always problematic? Like, are there kids with these issues that don't have disrupted sleep that doesn't affect the function?
Yeah, that's a great question. I bring these up because this is what parents are concerned about, but I mean, the seizures would probably be, of concern. I mean, you'd want to at least know about them, diagnose them. We don't necessarily treat all kids with seizure disorders with anti-epileptic drugs, particularly if they're occurring once a year. The benign Rolandic epilepsy is a good example of that. They're not driving, we don't have to worry. If they're felt to have a relatively benign, rare seizure, we'll sometimes just watch and wait, or particularly the benign Rolandic, they oftentimes will outgrow. The other ones are really much more benign, particularly the sleep terrors, the sleepwalking. They may occur in the setting of emotional stress or just sleep deprivation around the holiday season. The most important thing there is if they're occurring even once a year, you still want to be sure the safety measures are in place. So if the safety measures are in place, we've been able to evaluate them medically and feel that they're benign. They're meeting all the things we want. So let's say, for example, with sleepwalking, it's the first part of the night, there's a family history, it's only occurring when the child is sleep deprived or there's a lot of stress and excitement going on in the family. The family has not noted anything unusual like jerking of the movements or movements of the mouth or anything that makes you think seizure. They're only occurring, rarely. Then the only thing I would make sure is in place is the safety measures. And other than that, making sure there's no underlying sleep apnea or other cause, I would just observe. I wouldn't necessarily treat. The other extreme might be, the young adult, and I'm speaking not about autism here, I'm speaking just in general about anyone with these conditions. The young adult who's going off to college, who's on their own, who doesn't have a roommate, who lives on a high balcony floor. that's somebody I'm going to move to a lower balcony floor, try to get with a roommate, do those kinds of things to make sure that they're not going to hurt themselves during one of these episodes. Yes?
Is there an age time when the sleep terrors or sleepwalking start, or a time when they're more prevalent?
Yes, the question is, what about the age time? Usually 2-3 years around for sleep terrors, and about that age, a little bit older for sleepwalking. And usually by teenage years, the night terrors oftentimes sleep terrors normally they should resolve even by age 5, 6, 7. Sometimes they can last longer. The sleepwalking can last longer into the teenage years. And occasionally we'll see young adults who continue to have sleepwalking or sleep terrors. What would be a red flag that would make me want to study these individuals more is if they develop the sleepwalking or sleep terrors later in life, like in teenage years, and they haven't had it as a child.
I have some families, and I don't know if it's just coincidental, but they've reported when they've used melatonin that it was the first time the child had an episode of a sleep terror. And you mentioned like 3 side effects of melatonin from this study, and sleep terror wasn't part of that. So do you think that was maybe just a coincidence? I'm in pediatrics, so these children are between 3 and 4 years. So.
Yeah, it's interesting. We specifically looked for sleep terrors and seizures being more prevalent when kids started on melatonin, and we did not see it either in our, in our retrospective study or in the prospective study that we did, meaning we actually treated kids and followed them forward. But it has been described in literature. The seizures I don't necessarily believe, because there was only one report of increased seizures, and many other studies have not shown the increased seizures. Other studies have talked about sleep terrors potentially being more prevalent, and it almost to me seems to be in the same category as the what I mentioned about the bedwetting or the nocturnal enuresis. In order to have a sleep terror, you have to sleep, right? So it may be that these kids were prone to sleep terrors, but because they weren't sleeping, so we may actually, if I masked something with the melatonin, not that the melatonin was causing the sleep terror, but it was actually allowing them to sleep. So I don't really know for sure. I do know that in our retrospective review of 107 kids, the families were very pleased. Most of the kids were sleeping quite well. It made a big difference in terms of how they were functioning, and it probably made up for, in general, it would be a good thing as compared to not putting them on it and not having the sleep terror. But your point is well taken. Let's see, in the back.
How do you know when to take your kid off melatonin, and how do you know that they're sleeping well?
Right. So the question is, how do you know when it's time to take your child off melatonin, and then when you take your child off melatonin if they're sleeping well? Yeah.
How can you tell they're sleeping well if they're on melatonin?
Oh, okay. So in terms of knowing if they're sleeping well on melatonin, I think combining parent report, combining what you observe about your child with potentially saying to your doctor or healthcare provider, can we do some actigraphy, would be great. And that may be where you want to get a referral to the sleep specialist. There are things on the market like Fitbits and all. They're not validated. I'm not saying you couldn't use them. I prefer to use the actigraphy, but then again, I have families come and see me. But that's very helpful because you can actually monitor what they're doing and make sure, because as the kids get older, sometimes they'll wake up and you won't even know that they're up. In terms of when to take them off of melatonin, what I'll do, sometimes a child will initiate melatonin and behavioral measures together because the family is just really overwhelmed. And what we'll try to do over time is do more and more behavioral measures and then see if we can stop the melatonin, because parents oftentimes would like their child to be on as little as possible. It's good practice to be on, try to be on no meds rather than anything, and just see what happens and see if we can kind of substitute the behavioral. Also, as the child gets older, they can learn, they have more tools. They can learn how to self-soothe more as they get older. So I think that it's certainly worth a try. I don't worry too much about it or stress too much about it. If the child needs it, I'll keep the melatonin going. I have children who've been on melatonin many, many years, including into their adolescence, without any detrimental effects. But I will try, certainly I will try to withdraw it if the parent feels like that would be their preference, usually in combination with implementing behavioral strategies. Yes?
I have twins with autism, and both have sleeping problem. There is any particular study for, especially for twins or multiples?
So, sleeping problems in twins with autism? I don't think so, other than I've had twins and even triplets in my practice who I've treated, and the parents have been able to kind of do, like, just incorporate both kids into the bedtime regimen. It's interesting to me, sometimes there's differences. Sometimes they'll both be on the autism spectrum, but one may have more severe sleep problems than another, or one may be, they may even be different problems, like one may have problems falling asleep while another may have more problems with night wakings. I'm curious, do your twins sleep similarly, or?
I used melatonin to put them in sleep, and it seems working well. But they both wake up middle of the night. But it's not usually the same night. It seems like they are taking turns. Like I don't sleep, but sometimes they get sleep. Like this month, like one is waking up all the time, but the other one's sleeping well. And next month, this one is waking up all the time, and the other one is sleeping well. And I'm like, I don't get sleep all the time.
Oh, no.
Somehow they are getting sleep.
Yeah, so what I would say is try to come up with a plan, and we'll talk about it this afternoon, that works for both of them, and try to be consistent with the bedtime routine with both. And the more you can do with both, I know, my heart goes out to you. And we'll also talk a little bit this afternoon is things can change over time. So you're right, you could have with just one child and they're sleeping great for a while, and then something new happens, and things get out of kilter, and if you multiply it by 2, you have more possibility of that happening. But let's try to talk some more this afternoon when we talk about the behavioral. What I want to focus on this afternoon is behavioral treatment of sleep. Now that you have some of the context for why children with autism don't sleep well, what the causes are, what the medical issues are, how to partner with your provider, and talk about the concepts of sleep education. How do we implement them, from toolkits to books to formal sessions? Get your input on that, and then invite parents and therapists to share their questionnaires, grandparents, other relatives as well, and design a behavioral program. So I want to start out with this quote by Lucy Wigg. She actually wrote not about autism, but about intellectual disabilities. And it's really been a profound quote for me, and I've used it a lot in my talks and in talking with parents. Behavioral treatment of sleep problems in children with intellectual disabilities and challenging daytime behavior reduces parent stress, increases parent satisfaction with their own sleep, their child's sleep, and heightens their sense of control and ability to cope with their child's sleep. And I really believe this is true in my practice, and I've watched families who, sure, if they give their child a pill or melatonin or whatever, and their child is sleeping better, that's great. Everybody's happy. But I've really been impressed with the families who, when they've implemented a behavioral intervention for sleep, and come back and told me, wow, this is amazing. My child is sleeping for the first time in years. And I'm looking at this, one of the families who was in our parent sleep education research program that I'll tell you about at the end was at the University of Colorado, and she gave a quote for our book. And she wrote, "The picture schedule worked like a miracle the very first night, and my daughter fell asleep in minutes rather than hours." And it was more than just the sleep improving, which is huge in and of itself. It was the family's sense of confidence and competence with their own sleep and their ability to parent their child. In fact, we used the parenting sense of competence scale, which measures a parent's feelings about how effective they are as a parent and how satisfied they are as a parent in our research study, and showed that that scale improved with parent sleep education. So I think we're giving not only the gift of sleep to the children with autism when we help their parents, but we're actually helping the parents. And as I said earlier this morning, when you help the family and you help the parents, you're not only helping the parents, but you're helping the whole family. You're helping the children, because if the parents are calm, the children will be calm. If they're better slept, they'll be able to be better advocates for their children. So anyway, I just wanted to elaborate on this quote because I think it is really meaningful and significant. So I'm going to talk about a case, and we can walk through what we did for Mikey, but I want to just present it, and before we even get into the specifics of behavioral sleep education, see how much you guys already know. Mikey is a 6-year-old boy with autism and insomnia. He enjoys a glass of Mountain Dew as dinner, and he recently got an iPad for his birthday, on which he plays this very stimulating video game that many of you have probably heard of called Angry Birds, although it could also be Flappy Bird or some of these other games that are going around. He goes to bed at 8 p.m. He has difficulty initiating sleep. He'll often sing songs from his video games, including the Angry Birds one, for 1 to 2 hours before falling asleep, driving his whole family nuts, of course. And he'll be overly active during the day. He's always on the go. His parents are exhausted. His mother has started sleeping with him so that the family can sleep. So before we even get into the details, would people like to volunteer what maybe we can do to help Mikey fall asleep, or what some of the issues are here? Yeah, go ahead.
No Mountain Dew.
No Mountain Dew, good idea. What's that?
And no iPad.
Mm-hmm. No Mountain Dew and no iPad. What else?
Could you change the game that's on the iPad, though, to be like a matching winner or something that's connecting instead of something that's...
Yeah, so could we change the game on the iPad? That would certainly help. As we talked about this morning, we still have the light issue and the stimulating issue, but I agree, that would help a lot. Particularly maybe do a matching game after dinner so he still has some computer time, but then turn off the electronics an hour before. Other things? There's something else on here that I haven't spent that much time talking about. I did mention it this morning, though.
The mother sleeping with the child?
Well, the mother sleeping with the child, I think we mentioned this morning, even though there are cultural preferences for co-sleeping, in the majority of kids that I've seen, the parents are sleeping out of necessity, the child waking up, worrying about it being a safety issue. But there's something else about the sleep. Yeah?
Earlier bedtime, because it's taking them so long to fall asleep.
Yeah, exactly. The 8 p.m. bedtime may actually be too early for him, and I'm going to show you a slide on that. Yeah?
Changing the bedtime routine from being the games to being something quieter?
Yes, exactly. So not only taking away the stimulating video, but substituting something that's more calming. Excellent. Yeah.
It says that he's overly active during the day and was on the phone. So just engaging him in heavy purposeful activity, like heavy work during the day.
You make a very good point. The idea of engaging in something purposeful, heavy work, exercise during the day. So daytime habits can be as important as evening habits. It's excellent. I'm going to have nothing to say by the time we're done. Go ahead.
Sing song is good, but it comes from video game song, so maybe can change it to like Tinkle Little Star or something soothing him for sleep.
Right. The idea that this video game is not only stimulating, it's resulting in his having this kind of repetitive behavior, the sing-songing, that could then interfere with sleep, not to mention the rest of the family's sleep. Yeah, excellent. Good. Well, this is a really good start, and I want to walk through a lot of what we've just talked about in a little more detail now. So, components of successful sleep. So as we heard, it's not just what happens at bedtime, it's what happens throughout the day. So daytime habits, evening habits, the sleep environment, bedtime routines are all really important. And sleep hygiene, you may have heard that term, is used to describe a person's daytime and evening habits that contribute to successful sleep. So they're all important. And one of the questionnaires in your book is the family inventory of sleep habits. And we developed this to use in our research, but we've really used it practically as well. This is the research version, which is 12 questions. It's short. We can use it to measure change with interventions. But the longer version in your booklet asks about even more questions, and we use it to identify areas, not just at night, but during the day, where the families can make improvements. It's tricky because when you first look at it, you're like, well, a family knows, that they know that they're supposed to fill it out a certain way, right? I mean, my child gets exercise during the day. You're probably not supposed to write never, right? But on the other hand, it is a really valuable tool, given that. I mean, we don't necessarily use this to say, well, they've definitely improved and the child should be sleeping better because they went from saying the child never exercises to usually exercises, because there still may be an element of the parent knowing how to fill it out. But it is really, really helpful, I think, for a busy clinician or a parent to be able to just take an inventory and say, these are the areas that I can work in. So we use it in that way, and we use it to say, when I show you my behavioral sleep education program, we try to do everything in an hour with the families, and we've shown that that's been very successful, but it's very individualized. So in other words, this is a way of making it individualized. This is a way of being able to say to the family, let's look at this and focus on the areas that your child needs the most help on. This is a way of saying to the therapist or the nurse or whoever's providing the behavioral sleep education, this is a way of targeting the areas, and you're limited time with the family, and you have limited time, and they have limited time. Where's the money? And if you get a response like, in the hour before bedtime, my child engages in exciting and stimulating activities, usually it could be a great opportunity to educate the family and come up with more bedtime appropriate activities. So this is how we use it. And we'll talk about more when we invite one of you up to go through this. And then the daytime habits, which are covered on the family inventory of sleep habits, include abundant exercise, abundant light, limiting caffeine, limiting naps, limiting the bedroom to not doing timeouts in the bedroom, not having a computer or a TV in the bedroom. It's not always possible if it's a small house or there's only so much space in the house. Sometimes you do have to have the child's computer or TV in the bedroom. Maybe not TV, maybe that can be in a family room, but let's say they need a computer for schoolwork. But what you can do is you could say goodnight to the computer. You could put a sheet over the computer at bedtime, or if they have a laptop or an iPad, it can go into a certain part of the house. And the idea is the less they use that device in their actual bedroom, and hopefully never in the bed, they won't associate the bed and the bedroom with that device. So let me give you an example from my adult clinic. I had an accountant as an insomnia patient. She didn't have autism. She was an adult, but it's a good example, I think, to illustrate this kind of learning to associate the bed and the bedroom with something that isn't promoting sleep. So she was an accountant, and for fun, I guess, and to relax, she would balance her checkbook when she was in bed at night before she went to sleep. Maybe that's why I'm not an accountant, I don't know. But that's what she did. And she would wake up, have trouble falling asleep, wake up sometimes thinking about numbers, and she had basically associated the checkbook balancing with her bed. So that's what you don't want to do, and that's why the timeout should be in a different room if you're going to use that with your child as a form of discipline. Your TVs, your homework, everything else, you want to try to move out of the bed. So that's what the selected bedroom use is about. Evening habits, limiting stimulating activities, TV videos. I love this book, Goodnight iPad. It's a spoof on Goodnight Moon, and it's written by Android. It's actually really funny. They have a big electrical outlet, and they have they have all sorts of interesting things in it. So it's very funny, but it really is a good illustration of needing to say goodnight to the iPad and the tablets, and dimming the light, because we talked earlier this morning about how light can suppress natural melatonin, and putting these routines into place. And one of the really neat things about kids with autism is many of them crave routine, and you can use that to your advantage in implementing a bedtime strategy. And then the sleep environment. And this is where it may be counterintuitive. You might think, well, cool temperature, good textures, but sound should be minimal. It should be as quiet as possible, and light should be minimal, but not always. So you really want to individualize it. So my son, for example, was very anxious, and would get very anxious if we closed the door, the room was pitch black, there were no sounds. He would really start freaking out. So what we found was if we left the door open and he could hear the sounds from the house drifting up to his bedroom, if we had a night light, it made a tremendous difference, because then he felt more comfortable than if it were completely pitch black and quiet. So really individualizing the environment to what works, and playing around with it. The other thing that works really well is a dimmer switch. So a child who's used to having the light on because they're scared, if you just turn off the light, it's not going to work. But if you could put in a dimmer switch and very, very gradually every night dim the just a little bit, that can be very effective in promoting a dimmer environment. This is the slide I was talking about earlier that I think is really helpful for understanding sleep needs and amount of sleep. So there's actually 3 issues. There's amount of sleep, timing of sleep, and regularity of sleep. And they're all important in sleep hygiene and sleep habits. And the way I explain it to parents in clinic is I actually show them this diagram, and I talk about this first. So this dark line is this homeostatic drive to sleep. And what I say is that over the course of the day, this is alert, this is sleepy. We actually go from alert to sleepy. Here it is, I'm sorry. This is the dotted line here, the homeostatic drive. We go from alert to sleepy as the day goes on, and we get sleepier and sleepier. Something builds up in our bloodstream. We're not really sure what it is. People think it might be adenosine. Adenosine is actually a neurotransmitter or a brain chemical that caffeine competes with. So when we have a cup of coffee or a glass of tea or whatever, it actually obliterates this drive to get sleepier and sleepier as the day goes on. What's another thing that could obliterate our sleep drive and make us more alert that we could do during the day? Exercise, that's very good, or a nap. And if you think about it, naps and exercise are kind of different in a way, because exercise will actually make us sleepier after we exercise. And ultimately, when we go to sleep at night, if we've exercised, we're going to be more prone to go to sleep because we're more worn out. While a nap or caffeine does the opposite, we may be more alert, right? So that's why exercise is so good, is it keeps us awake and alert during the day, but it also allows us to continue to kind of prepare ourselves and get ready for bed. So that's the homeostatic drive to sleep. And the reason we don't fall asleep, let's say eating dinner or getting ready for bed, is because we have this other drive that kind of boosts us up, and that's the circadian drive. And that is that second wind that a lot of us experience. And when you combine the two, you get kind of this little bump called the forbidden zone. Sorry, I'm having trouble with the mouse. Here we go. And this is right about an hour before we're ready to go to sleep, we're more awake. We're fully awake. In fact, we're more awake an hour before we're ready to go to sleep, an hour before our natural bedtime, than we are at any other time during the day. So it's really important to time your sleep right, because if you put a child to bed too early, or we go to bed too early, we're actually less likely to fall asleep, and we have more trouble. And that gets into that whole kid who can't fall asleep, and they're fidgeting, and they're restless, and they're lying awake, and they're anxious that they can't sleep. And that is detrimental to sleep. So finding the right natural bedtime and making sure that we don't go to bed too early can be really important. Now, how do you know when the right natural bedtime is? It's not necessarily that straightforward. You sometimes have to play around with it and try, different times. But the example I would use is, let's say that we normally go to bed at 10 o'clock at night and we have to catch a flight the next morning, and we're going to bed at 8:30. We're going to go to bed super early, right, so that we're ready for the next day. And, we're lying awake in bed at 8:30, 9, 10, maybe even 11, maybe even after the time we normally would have gone to sleep, because our mind has been restless and ruminating, and we've been trying to fall asleep when we can't fall asleep. So that's why picking the right bedtime is so important, and trying not to pick it too early. And that's the whole concept of the timing of sleep. And then the regularity fits into the timing, because if you can go to bed at the same time every night, the brain learns when to secrete natural melatonin, right? And it gets into this groove and this habit. And the consistency is really important. That's where the teenagers who go to bed at 10 o'clock on a school night, or even earlier on a school night, and then they stay up till 2 a.m. on a weekend, are going to get into trouble because they don't have that consistency. And then the final thing is the amount, and that's what we talked about earlier, that in our quest for our kids to fit the books and have 11 to 13 hours of sleep if they're preschool and 9 to 11 hours if they're school age, we could be defeating the purpose, because they actually get much less than that, because we put them to bed too early and then they're not ready because of this diagram I showed you, and then they're awake. So I'm not necessarily advocating for kids having less sleep, but what I am advocating for is that we be a little bit more realistic and scientific, realistic and scientific at the same time, I guess. We understand these concepts. We make sure we're not putting our kids to bed too early. We realize that delaying bedtime from even something like 8 to 9 or 8:30 to 9:30 can do wonders for improving sleep. With the same token, there are family issues, and I was talking at lunch with several people about this whole idea that even though you say to a family, and it's so funny when I see a family, let's say I'll see the kid and the kid's 10 years old and very verbal, and I'll say, well, you know, have you tried going to bed at 9:30? Have you tried having your child go to bed at 9:30 instead of 8:30 because they're lying awake and they can't fall asleep? And invariably the child will give me this big grin like, that sounds great. And then oftentimes it will be a child, but the parent won't, but I'll get to that in a minute. Oftentimes it will be one of these really verbal, kind of high-functioning teenagers with Asperger's who will say, Mom, I've been telling you this for years. Finally, the doctor agrees with me. I need to go to bed later. There you have it. But I think that what the parent is feeling is, how am I going to get everything done? How am I going to have some time for myself? How am I going to explain to Johnny's sister that who's typically developing at 8 years old, that she can't stay up till, 9:30 or 10:30 or whatever we've decided? And what normally will happen is they'll just leave and they won't do anything unless you're astute enough to ask the question, which I now do routinely. I'm talking more to the therapists in the audience and the parents at this point. So do you think you think this is possible, or what concerns do you have about this? And then all of those concerns will come out. So this is something I've learned over the years is fraught with concern. Even if the child or the teenager is, yeah, the parent oftentimes has a lot of misgivings about delaying bedtime, especially with bedtime being, with school wake-up times having to be as early as they are, at least in the States. Our high schoolers have to wake up at 6 to get to the bus and all of that, and it doesn't bode well when you're trying to tell a parent to go for a 9:30 bedtime rather than an 8:30 bedtime. Yes, you have a question?
Relate to the time of year, like as far as how long the sun is out in summer versus in winter?
That's a good question. Does it relate to the time of the year? Yeah. I mean, it relates to, first of all, being in school versus being out of school is huge. Parents are much more willing to do this when their child is out of school because then they can still get, or at least try to get their, whatever the books say they're supposed to get. So, putting a child to bed at 9:30 rather than 8:30 outside of the school year often works better. And then the other issue is with the light. Oftentimes, they realize it's really hard to put the child to bed earlier if it's still light outside. So what we may oftentimes do is capitalize on the summer as an opportunity to try this and see if it works. And then tell the parent that 2 or 3 weeks before school starts, we can always back it up. So let's say we move Mikey's bedtime from 8 to 9 or 9:30 for the summer, and now he's falling asleep within 20 minutes or half an hour. Now we back it up, right? So now he'll, a few weeks before school, we'll do 9, and then we'll do 8:50. A few days later, then we'll do 8:40, and we can actually maybe get it not back to 8, but maybe to 8:30, and then the parents are happy. That makes sense. The other thing we could do with Mikey is we can move the, he can still do his Angry Birds, but he's going to do it at 8, he's going to be done by 8:30, and then we're going to start a calming, soothing bedtime routine that gives him an hour between the time he turns off his video and the time he goes to bed. Okay. Next thing I want to talk about are visual schedules. Visual schedules, we're used to them in kids with autism. We use them during the day for other things. They work. They can be very effective. We use them a lot in our clinics. I brought an example of what we do with Velcro strips that we have available for families, and then the kids can peel these off and move them around. We can incorporate choices. So if a child likes to listen to music or read a book, we can give them the choice of which they want to do that day. And we're going to go through a bedtime routines worksheet where we actually construct a visual schedule based on the worksheet next. The other thing I should mention, the checklists can be very helpful for older children, children with more language, who want to put a schedule together. They should participate in the putting together of the items. What do they really want to do? What order do they want to do them in? With the aid of the worksheet. So how does the worksheet work? So this is the first step in filling out the worksheet. The family looks at the activities on the left and checks whether each of them occurs, taking a bath, washing hair, variety of other tasks you might see here. And then, is the activity easy or hard, and is the activity stimulating or relaxing? I'm sorry, there's a typo. It's not simulating, it's stimulating. So the idea would be taking a bath could be really easy for a child, and they enjoy it and they love it, but at the end of the bath, they're really wound up and stimulated. Another child might find a bath to be easy and relaxing, while still another child may find it to be hard and stimulating. So it really depends on the individual child. It's hard for an activity to be, or it's unusual for an activity to be hard and relaxing. It's usually easy and relaxing, or easy and stimulating, or hard and stimulating. But making the distinction between these is important because it helps you figure out what tasks to put earlier in the night and what tasks to put later in the night and what tasks to maybe move out of the bedtime routine altogether. So if the child is finding a bath to be stimulating and hard, it may be an activity you want to move out of the whole bedtime routine and do after dinner. And then likewise with some of these other activities, brushing teeth might be really hard. Reading might be really might be stimulating or relaxing, depending on the child. And then we also have them rank other activities that aren't on this list. So we put other ones on, and then using the information from the bedtime routine worksheet, we have the family plan a bedtime schedule for their child. And this is where they rank the different activities in order. So this is an example of a completed bedtime routines worksheet. So the parent wrote down which activities occurred with an X next to them, and then labeled each activity as either E for easy or H for hard. So in this case, taking a bath was easy and relaxing. Washing hair was hard and stimulating. Changing into pajamas, getting a drink was easy and relaxing. Brushing teeth was hard and stimulating. Using the bathroom, easy, relaxing. And then the parent also put a couple of other activities that weren't on our list. Playing with cars was easy and relaxing. Watching videos was, as you can imagine, easy and stimulating. And then they ranked them in the order of preference that the child liked them. As you can imagine, watching videos was number 1. But playing cars was number 2, which is good, right? Because that was easy and relaxing as opposed to easy and stimulating. And then the other activities were ranked. And then with this worksheet, the parent was then able to put together a bedtime routine. So the brushing teeth was hard and stimulating, so that was early on. And then they took the videos out altogether. They put the cars in, though, and the drink and the bath and the bathroom and the PJs. And the child was still happy because they found another time of the day to do the videos apart from bedtime. And then the cars was still in there, so the child was happy. So the cars, so then you could go to this and you could arrange it in the order that would fit the bedtime routines worksheet. Okay? And then the next key is to teach the child how to do this. And we actually have a tip sheet, a quick tip sheet on the visual schedule. And it's not as simple as just you hand this to the child. You really want to have the child take ownership of this and have them physically go through it, manipulate the schedule, and reward the child for following the schedule. So even if the child, it's sort of like potty training, even if the child doesn't fall asleep with the schedule, just following the schedule every night and doing everything in order and being consistent, you want there to be a reward for the child because you want to show them that they're being rewarded for following through on a task. And we've been really, as I said, we've been really creative with these. You can, if you have a child with limited verbal skills, there's another tip sheet that talks about putting a schedule together using real items rather than picture items. For example, using a real bar of soap, real bottle of shampoo, real comb or brush, a real book, so that they can see these items, or you can have little boxes set up where they have box 1, box 2, box 3, and each box has the item in it. So you can be really creative with the visual schedule. Some people will take photographs because the photograph is easier for the child to follow than the picture icon. Okay, so we're doing well time-wise. I would like to take just a few questions, and then I wanted to see if we can get some parent volunteers up here or some therapist volunteers. So first of all, are there any burning questions on what I've said? Yes?
I have a question about napping. So if you have a child that gets up at 2 o'clock in the morning, 3 o'clock in the morning, and stays awake all day, preschool, intervention, the whole thing, often it's really hard to keep him awake for that consistency of
Right.
all that, because that's always done. But it really throws a big curveball in the scenario when you have a child that's up for, so I guess my question is, what is normal for a child to be awake? What is, like, we're talking about sleep, but how long does a child normally stay awake for in a day? It's normal.
Right, I see where you're saying. So, yeah, so there's a few things. The first is, my hope is that with implementation some of these strategies, the 3 a.m. will become later. Okay, so that would be good. The second is, I'm glad you brought up the question about the naps, because I didn't want to make it sound like we wouldn't encourage any naps. Certainly young children need naps, and even older children need naps on that kind of a schedule. And even, I have a teenager who wakes up at 6 a.m. to get ready for school, and he takes a nap in the afternoon. And I think after he does all of his school stuff, I think that there is a role for naps as long as they don't interfere with sleep at night. And I think that you just have to think about the timing. In general, if you're planning a 9 or a 10 o'clock bedtime, you don't want the nap to be any later than 3 o'clock or so in the afternoon. And it could vary. Some kids it needs to end by noon or whatever. What I've heard happen a lot is parents say, well, 4 p.m., my child has to have that nap, but then if they have that nap, they're not going to be able to go to sleep until midnight. And I can't put them down for 30 minutes because I can't wake them up. But if I wake them up after 30 minutes, they're belligerent and all. And what will sometimes help with that child is actually to do some stimulating exercise in the afternoon. Again, not too close to bedtime, but a walk or something, or in the summer, some sort of go to the pool or whatever, to try to get that kid over the hump. And then the advantage is they'll be sleepier at bedtime because they've exercised. Going back to your question. Or overstimulated, but that's why you don't want to do too close to bedtime. But what you're doing is you're kind of substituting exercise for a nap to kind of keep them awake and get them over the hump. It's really trial and error, because you may find that will work, you may find that it doesn't work, and you just have to sort of do a nap earlier or a brief nap earlier to get them through. And then, of course, everything's shifting and changing on you, so it's even more complicated because that 3 a.m. bedtime may now shift, right, when you put in a nap or don't put in a nap. So, and that's why what we do in our education is we try to teach these basic principles, because you can't mandate when a nap should be. It's not going to make any practical sense for the child.
And keeping the nap, obviously, not for a long period of time either. I think if he's going to nap, it will be like 2 to 3, that's it. Because that seems to make
Yes.
sense too.
That, Yeah, definitely limiting the nap, which is easier than said than done sometimes. And I've had parents tell me it's harder to limit the nap than it is to have them jump into the pool or whatever.
Yeah.
So, or play basketball or whatever. Yeah, it is a very tough one. Other questions before we, okay.
You talked about technology in bedrooms, and I'm just wondering what your suggestions are about toys in bedrooms.
Right, so we talked about technology. What about toys in the bedrooms? I think that it depends. I think some toys in the bedrooms are probably okay. Ideally, the toys would be in another room so that the child doesn't associate waking up and playing with the toys. But I think, you know, on a scale of timeout, video, and toys, I would probably say the toys are the third least, you know, less evil than the other two, or third on the list. And then some kids do find it reassuring to have a small toy in their bed. Certainly comfort objects would be fine and are often encouraged. Max, thank you for coming up.
You're welcome.
Can you, and I want you to tell us as much as you're comfortable with, no more than you're comfortable with. Can you give us, and you don't even have to name your child by name if you'd prefer. Would you like to tell us just a little something about your child?
Well, he's 5 years old now. He's nonverbal. He's about, I guess we're figuring somewhere in about the middle of the scale, but he's had a sleep disorder since birth. At worst, we were suffering through him sleeping about half an hour every 2 days, and maybe crashing for about 4 to 6 hours about once a week. And then now he's actually being sedated with quetiapine because he's been proven to be melatonin resistant. So I have to give him enough melatonin and knock out a bull elephant to put him to sleep. It's not fun. That's he's a little bit of a handful, but he's plenty fun.
Okay. And did you fill this out based on his behavior on the quetiapine or
Yes.
before? Okay.
What we've been dealing with
Okay.
for the past 2 years.
Okay, great. And I'm curious, when he falls asleep,
Yeah.
how early, like what time do you give him the quetiapine?
Well, we've adjusted it to about 7 o'clock, 6:30, 7 o'clock. We give it
Okay.
to him. He generally falls asleep before 9.
Okay.
Generally. Every day is different.
Okay. And when he falls asleep, does he fall asleep on his own, or do you kind of see him
He
just
has to settle
zonking
into,
out?
he's sort of developed his own routine. He doesn't fall asleep in his bed. He falls asleep in the living room. You're generally watching TV with like Thomas the Train or something quiet and musical on. And then once he's out, I can carry him up to his bed and he'll wake up on the trip up and then settles in on his bed. It's about what we have gotten down to, because if we try to put him up to bed in his bedroom, then it just escalates through the roof, and we have neighbors who need sleep.
Right. So he does best when he's falling asleep on the couch,
Falls
watching.
asleep, yeah, in the big couch, watching television when he's near us. He has to be near everybody
Okay.
else.
So he has to be near you, and the television has to be on.
The television doesn't have to
Okay.
be on, but it's helpful.
It's helpful. And then he'll fall asleep. You'll transport him upstairs,
Yep.
and
He wakes up on the trip and then goes back to sleep, cuddles in, goes
okay.
back to sleep.
Okay. So looking at the questionnaire, what I'm focusing on are your yeses responses and whether something's a problem. And I realize when we photocopied this,
a little chopped off,
it got
yeah.
a little choppy, but that's okay. You figured it out, and you put your own headings at the top, so that was great. So some of the problems are the child goes to bed at the same time every night being a problem, the falling asleep within 20 minutes, which, by the way, I wished you, the one pet peeve I have with this is the 20 minutes. And again, it was written for typically developing children, but it always seems like 20 minutes does not seem like a big problem. It's usually a lot more for people than 20 minutes. But you said he has trouble falling asleep within 20 minutes after going to sleep, falls asleep alone in his own bed is a problem. struggles at bedtime. So is that with the medicine that he struggles at bedtime?
yes.
Even with the medicine? Okay.
Even with the medicine, yeah.
Even with the medicine, he's struggling at
He
bedtime?
resists going to sleep.
Yes. And that's in that 7 p.m. to 9 p.m. window that's
At
happening?
any time, yeah.
At any
We've had
time.
him be up till midnight.
And then sleeping too little is a problem. Being restless and moving around in his sleep is a problem. Sleeping away from home. And then he awakens during the night, screaming and sweating
Yeah,
and
we've
inconsolable.
had night terror incidences.
Okay.
Where he doesn't even seem to recognize that we're there. So it's very strange.
So it sounds like in addition to the difficulty falling asleep, there's these episodes where he's waking up, screaming, sweating, inconsolable. And
then incidences where he's just waking up, period, and playing by
Right.
himself or crying because he's alone.
and they're kind of two different episodes,
Very
it
different.
sounds like.
You can tell them immediately upon going to check on him that you can tell the difference.
Does one occur at a certain time and another occur at a different time, or could they occur at any time?
Generally, the night terrors tend to happen closer to around midnight, and that's generally even when he just wakes up and cries a little and then goes back to sleep. It's about that same time.
Okay, so they're both occurring at similar times.
Yeah, but when he's just waking up and not being, like he's actually fully waking up, it's generally occurs closer to around 3 or 4 in the morning.
Okay, so that, based on what we learned this morning, that would fit,
Yeah.
right? That the night terrors or sleep terrors are more in the
Earlier
first part
on,
of
yeah.
the night. Okay, and those are the ones where he's inconsolable. And then awakening more than once during the night or once during the night are both problems. And then waking up in a negative mood in the morning is a problem as well.
Yeah, can be.
Okay. And falling asleep riding in a car can be an issue as well. Okay. So this is really helpful because what this is doing for me is I'm not only taking a history, I'm able to look at this as we take the history and focus in on certain areas and domains such as falling asleep, staying asleep, this whole idea of is there something unusual with these night wakings. I was able to review, some of the questions about snoring, and I didn't see where that was a problem. I didn't see where grinding teeth was a problem. It seems to me like the biggest challenges right now are he needs the medicine,
Yeah.
and even with the medicine, he's not falling asleep in his bed. When you transport him to his bed, he wakes up and then goes back to sleep. And then he's waking up in the middle of the night, sometimes due to a possible night terror, maybe,
Yeah.
but also has these separate awakenings that aren't. And that must be really disruptive to your family and really hard on your family.
Yeah, it can be.
Yeah. Is it every night that the night wakings are happening?
I think just about every night he at least wakes up and makes one little cry that we hear, but then goes back to sleep. He doesn't have like the night terrors every night.
Okay.
But-
Okay.
Yeah, he seems to wake up at least once every night.
Right. And at 3 a.m., when he has that second type, 3 or 4 a.m., do you interact with him at all? Or?
No, we try not to. We try
Okay.
to get some sleep while he's playing and happy.
Okay. Okay. And then does he fall back to sleep on his own?
Sometimes.
Sometimes. Okay. And if he doesn't, do you then go in, or?
No, at that point he's
you
up for the day.
He's up for the day?
Yeah.
Okay. Okay.
This is somebody who seems to be able to function perfectly normally on half an hour of sleep in a night.
Okay, so it's kind of luck of the draw if he's going to sleep or wake up, and if he does wake up, whether he's going to go back to sleep on his own or whether, okay, all righty. Okay, so the way I would approach this at this point in my clinic is I would, first of all, I'm really interested in this night terror, sleep terror issue, and I would ask some more questions and try to clarify. I would ask if you could possibly bring in a home video the next time. I would probably dig a little deeper, even though the snoring wasn't noticed here as a problem. I would ask specific questions about snoring, about noisy breathing. I would ask about family history of sleep apnea, because I want to be absolutely sure. So let me just do a little bit of that and we'll see. So in terms of these events at night, the 11 p.m. ones, the night, we're calling them sleep terrors or night terrors. Do you think your son does the same thing in each event, or are they slightly different? Or, in other words, do you hear him cry out in them? And
Yeah, he generally makes a small cry at least. Usually it's one cry, maybe two, and then he goes back to sleep, or he'll go into the full out screaming, bloody terror, night terror thing like you showed in your video there.
Right. And when you interact with him, can you console him? Can you get him to calm down?
No, if he's having one of those episodes, we'll spend usually up to 15 minutes trying to comfort him, and then he just kind of stops on his own and goes back to sleep. And he doesn't act like we've touched him or picked him up or anything, even if we've been picking him up and holding him the whole time.
And are his eyes open or closed
Oh, yeah.
to them? They're wide open, okay.
They're wide open, but he looks through us.
He looks through you.
Doesn't see us.
Does he move an arm or hold a hand out in any particular way?
Not particularly,
Okay.
no. But if I pick him up, he will put his arm around me in like a death hold, but he will put his arm around me.
Okay.
But he's not, it seems to be more the contact that he's reacting to than actually knowing I'm there.
Okay. And does he ever shake or tense up or have any
There's
jerky
a
movements?
little bit of shaking, like
Like a
reaction.
shivery
Yeah.
type of a shake, but nothing
Nothing all tensed up.
rhythmic or
everything, no.
jerking. Okay, good. Is there anybody in the family who has seizures?
I have had seizure-like things, but I was tested and I don't have seizures.
Okay. Is there anyone in the family who has snoring or?
Some of my family's infamous for it.
Do you snore?
Not particularly terribly, but apparently a little.
A little, okay. Does your son ever have snoring or noisy breathing or?
He can breathe a little loudly, but not terribly noticeably. It's just deep breathing.
Just deep breathing, okay. Okay. Does your son ever kick his legs in his sleep?
Yes,
or
sometimes he does do that.
Okay.
I've learned that the hard way.
And has he ever had an iron level, a ferritin level checked?
That's a good question. Has he?
He's had his iron checked, yeah.
He has?
That's a ferritin.
No, okay.
But not the ferritin, okay. And do you know if it was normal?
I think it, yeah,
Okay,
it
the
all came
iron
back
level was
normal.
normal. Okay, but not the ferritin checked. Okay, and then anything else he does in his, so the night terror, what we're calling the night terrors is once a week, or it can be more frequently than that?
It can be more frequently than that. Like I said, he makes that little cry, then goes back to sleep. He does that almost a night, every night. It's like 5 nights a week at least.
Okay.
But the night terrors itself, where it's the full-on episode, is maybe one every 3 or 4 months usually.
Okay, good. Okay, so it's one every 3 to 4 months. So in this particular guy, what I would say is, because it's happening one every 3 to 4 months, the chances of getting anything on a sleep study are going to be pretty slim. But there still may be some merit in investigating with a sleep study. I'm kind of on the fence. I'm probably thinking I wouldn't necessarily jump into it at this point because I'm not hearing a strong history of snoring. I'm hearing you snore a little bit. I'm not necessarily hearing that we have restless legs, although it might be a good idea to check the serum ferritin level the next time he needs his blood drawn for something. I'm not hearing anything concerning in the spells themselves. I'm not hearing jerking, rhythmic activity. Do you have safety precautions where you'll know if he gets up?
We have a
Yeah.
gate across his gate so he can't
Okay,
wander the house and
Okay.
get into things.
My approach would probably be, in this particular guy, to try to implement some behavioral sleep strategies to help the night wakings at 3 a.m., you know, those that are really happening much more frequently than once every 4 months, and then also work on some strategies to help him fall asleep. And those would include, we haven't gotten to the strategies for the night wakings at 3 a.m. yet. We're going to do that after the break. But in terms of the falling asleep strategies, this is where I would, you know, do a family inventory of sleep habits. I would put together a bedtime routine. And what I would do is I would work on trying to get him to fall asleep on his own, even if it's still with the medicine, because what I'm hearing is, and correct me if I'm wrong, I'm hearing that he's tending to fall asleep. Potentially the medicine is kind of kicking in. He's falling asleep, but then you're moving him. And when you move him and he falls back to sleep, it's kind of setting him up for when he wakes up in the middle of the night, because now he's in a different room, he's in a different place. He had kind of naturally fallen asleep
That
on the
doesn't actually
couch.
seem to bother him too much. When he wakes up, he's perfectly happy where he is, as long as he's not having one of those where he doesn't recognize anything around him. The trouble with moving him prior to him actually drifting off is if we do that, then he gets upset and it escalates, and then he starts resisting the medicine even then, and then he doesn't sleep. So that is our one problem with trying to get him to sleep in his own room, away from everything.
Right, right, that makes sense. So the next step might be to put, with the goal that he learns how to fall asleep in his bed, because then if he wakes up in his bed, and I agree, he's not waking up upset, which is good, but there still may be an element of he wakes up and he's, you know, ready to start his day, and he might stay asleep longer if he learned how to fall asleep in his bed. At least we could test that and try that, is to come up with some routine that would allow him to fall asleep in his bed. It might mean temporarily whatever you're using to help him fall asleep in the room, like being there for him, you know. It may mean cuddling with him in his bed and then getting out of his bed. But the idea, trying to have him in one place so that, what we'll talk about in a few minutes is this concept of when we wake up, we need the thing that we had. The last thing we had before we went to sleep needs to be there when we wake up. So it may be that having you there, the tricky part is to not have him fall asleep with you in the room, but to at least do his comforting and his falling asleep on his own where he's physically going to be, and then it would keep him, you know, allow him to go back to bed at 3 in the morning. We could try that.
Yeah, we could try that.
Yeah. Thank you. Thanks for coming up. Do you want to introduce yourself?
My name is Yuki. I have twin boys who are 3 and 10 months old. And they are both diagnosed with autism when they are almost 3, so about a year ago. And like they have different problems. Like they both have problem falling asleep, so I started give them the melatonin.
Can you speak up? Yes, they can't hear you. Can you speak up a bit, Yuki?
Okay. So they both had problem to fall asleep. So I gave them melatonin, and it seems work, but to fall asleep, but it's not working for the staying asleep. And my pediatrician recommended to use
fast acting and long last acting, but the problem is they cannot swallow the pill and they cannot use the long lasting.
Long lasting, so I think what you mean is the time release
Yeah,
or the
time
extended
release,
release.
yeah,
Okay, yeah. So let's go back to the melatonin and later, but let's talk a little bit about your responses on the family inventory of sleep habits. So I'm going to go through sort of some of the key ones, not necessarily everyone, and kind of put this together for you. So the first is, my child gets exercise during the day. You wrote always.
Yes.
That's terrific. Can you give me some examples of some of the things your child does?
They're in preschool.
And you're going to talk about both of your children, right?
Yes,
Because they're
yes.
twins. Yeah,
Yes,
yeah.
they are both in a preschool.
Okay.
And rain or shine, they always get the outside time at least 1 hour every day. So they are always active outside, and on the weekend, I try to bring them at the park, or if it's raining, we are living in a condo, but I let them running around in the hallway or up and down the stairs. So and they enjoy the active play.
Wonderful. So they go to the park every day, even if it's raining, they run around up and down the stairs. That's really good. And that's what I do with families is I don't stop at my child gets exercise. I really try to figure out what that exercise is and whether it's giving them what they need and then the other thing I ask is, how do they feel after they exercise? Do they feel kind of, do they look like they've kind of put themselves out and they're more tired and all, or are they more stimulated after they exercise?
It depends on the day, but sometimes still excited if they want to go more, but sometimes they are so tired they just want to be quiet and sitting down and eat snack.
Mm-hmm. Okay. And have you noticed a relationship between exercise and sleep? On days that they get more exercise or less exercise, are they more apt to sleep more or less, or go to bed easier or harder? It's hard to tell.
Yeah,
Okay.
even they take a nap or not doesn't really affect the sleep of the nighttime. So
Right, not so much if they've napped or not, but if they've exercised vigorously.
well,
Does
they're
that?
always getting the same amount of
Okay, so
exercise.
they're always getting.
Yeah.
So which point I'd say that's great. Keep up the good work. Let's move on to the next aspect. But it's great that you do that. That will be good for their overall health as well. And then the next question is about naps. My child naps more than 1 hour during the day sometimes. So tell me a little bit about that and the twins.
They're in the preschool from 9 to 2, and our commute is like a 45 minutes bus ride. So they usually fall asleep on the bus, and even we get home, I move from stroller to the crib, or I try to wake them up. They just doesn't respond well.
Mm-hmm.
I'm trying to keep their nap time maximum an hour, but sometimes they just doesn't respond and just get so cranky, and they have the BI session from 4 o'clock, so I always make sure waking up them by 4 o'clock, but sometimes they sleep hour and a half.
And if they tend to sleep an hour and a half, how does that affect bedtime? Does that make a difference, or?
Little bit later,
Mm-hmm.
but it's not necessary to
Okay.
breaking up.
It's not that big of a deal. Okay. So I think in your case right now, even if you wrote my child naps more than 1 hour during the day, sometimes, as long as it's only on not the norm, and it's not affecting their bedtime sleep, we're probably okay there. One thing I've sometimes tried for naps when a child really needs a nap and it's going to make a big difference in how they function the rest of the day is to actually try a small dose of melatonin. I know you said they were melatonin resistant, but you could try a small dose of melatonin before the nap. And the beauty of the melatonin is it's short acting, so it won't affect them the rest of the day. So you can try that. And then the other one I wanted to highlight was you wrote that you really never use the bedroom as a timeout, so that's fabulous. So keep up the good work there, because then we won't have that association. So what I'm doing is I'm also pointing out to the parent what they're doing right, and I think that's really important, to not focus on the negatives, but there's a lot of really positives here. And the other thing I wanted to talk about is I'm seeing that in the hour before bedtime, my child engages in relaxing activities usually, and in the hour before bedtime, my child engages in exciting or stimulating activities occasionally. So that's really good, that it's more of the case it's the relaxing and less of the case that it's the stimulating. Tell me a little bit, and I appreciate your being honest, tell me about the occasionally engaging in exciting and stimulating activities and what that looks like.
If just one kid is fussy, I can handle. But if both of them get fussy at the same time, I just give them the iPad to calm them down.
Right.
Because, it's just too much.
It's too much to handle them both. That makes a lot of sense. Are there any activities that you could come up with when one of them is fussy that might calm either the fussy one or the other one, or let's say they're both fussy? Is there anything that they could do together? How old are they, did you mention?
It's 3 and 10 months.
Okay,
and
yeah.
they are not really interacting.
Exactly, exactly. Is there anything they can do on their own that would calm them, that you could give them to do?
One kid loves book, but he loves book too much and he mouthing a lot. I used to give them the book like to calm him down, but he once actually choked.
Oh wow! Okay.
Because he can read the page and like put whole thing in his mouth, and he was just literally. And once that incident happened, I didn't give him the book anymore, and I'm trying to find some substitute to calm him down, but it's not finding yet. So,
Right.
yeah.
Do you work with a therapist? I mean, are they in occupational or speech or?
But we don't have the private one, so we can see them every 3 months.
Oh, okay. I understand. Because I was going to say they may have some suggestions. The other thing I've seen is some of these cloth books. I mean, I guess he could still put them in his mouth, but if they're big and, he wouldn't be able to rip the pages out.
We have the cloth books, but he doesn't not really interested.
He's not really interested in those. Okay. The other thing would be you could look for just one of these big books that's about this size that has like the plastic, that it would be indestructible in a way. He couldn't really,
Yeah, I'm trying to find plastic books, but where can I find it?
Kids books. It's a store in Vancouver called Kids Books.
Okay.
Yeah.
I'll help you find it.
That would be wonderful. So the idea is we'll move on and we won't talk about books, but this is an example of how you want to be individualized. We found something that her child really likes. At least one of the twins is really into the books. Now it's just tweaking it a little bit, because that would be a great thing for that child to work with while you're trying to calm your other twin or whatever. That would be less stimulating. And books are interesting because sometimes a child will read the same book every time and it will be calming. Sometimes it will be overstimulating because they'll start doing repetitive behavior with the book. Sometimes a new book will be too stimulating. So you really have to individualize, not just making sure that there's going to be no choking hazard with the book, but the book itself. What about your other twin? What kind of relaxing activities does your other twin like?
He has favorite blankie, so it helps him. But but not always.
Not always. Okay. It sounds like he might is the blankie smooth and soft?
Silky.
Silky. Okay. So it might help with the other twin to try to find something he can do, that would relax him, that's tactile.
Yeah, the other twin likes my house gown, the house coat. Yeah, he hold it and carrying it everywhere he goes.
Right.
When he's really upset, it's not really helpful.
Right. The other thing I wanted to make you aware of is the sleep tips for children with autism who have limited verbal skills. There's a lot of sensory type activities in here. He might enjoy wearing a weighted blanket or some sort of rocking or swinging or something, and
Yeah,
you know.
He loves swinging, but we are living in a condo in a
Yes.
limited space, and there is no space to
Right.
put the swing.
Right.
We used to have the jolly jumper,
Right.
the little ones, and he loved that, but we cannot have the space for the bigger kids swing.
Sure, sure. But the idea is you might, when you do have the time with the OT, and I realize it's not as frequent as you'd like or you're able to, but you could ask the person for some activities to calm him, because it sounds like there may be ways to kind of get them both relaxed, and then we could build those into the bedtime routine. So that's really helpful. You're doing a great job with caffeine, never.
Yeah, little.
And we actually have caffeine sheets that I can give you one to post on ACT that go over the amounts of caffeine, because sometimes we don't remember that chocolate milk or coffee, ice cream, or even iced tea. A lot of families don't realize that iced tea has caffeine in it, the tea. So we'll go over that when we talk about that item. And then the other things I'm seeing on here are really excellent. I mean, it sounds like the room is dimly lit, it's quiet, there's consistency with bedtime. The child usually follows a bedtime routine that lasts 15 to 30 minutes. Let's talk about that for a minute. What does the routine consist of? And you do it together with your twins together?
Yes.
Okay.
I gave them bath from 7 until 8 o'clock or something like that, because they love bath time and they get so excited, but by the time the end, they both get relaxed and chilling. So, and after that, I put the PJ on and give them night-night milk and just put the music on, and they know that that's the cue to go to sleep. So they love listening to the music and fall asleep, but it's not always, but that's usually works. Yeah. But they hate brushing their teeth because I'm giving them the milk with the honey in it. I usually brush their teeth right before going to sleep, and sometimes
So that's a challenge. So and I know we're overlapping a little with the bedtime routine, but I'm going to do it anyway because I think this is really useful and helpful. So the idea is you give them the honey with the milk because it's soothing and calming, but then because they have to brush their teeth because they've had honey and milk, it kind of counteracts it. Can you think of another item, something else that would be calming? It sounds like maybe the music you were saying is calming. Okay, so in this case, if we were putting the bedtime routine together, what I would say is there's nothing wrong with the honey and the milk and the brushing the teeth, but I would probably do that earlier in the bedtime routine to try to get the, and that might even be an incentive to get your child getting ready for bed or get the twins ready, as they know they're going to have the honey and the milk. But after they brush their teeth, you want to try to unwind them again. You want to try to unwind them. The other thing would be to do the honey and the milk earlier in the day and just take it out of the routine altogether, because that way.
the melatonin in the honey milk.
Right.
And
Yeah.
it seems like that's the great timing to give them the melatonin, because then after that.
Oh, I'm sorry, melatonin. I'm sorry, I thought you said honey. I'm sorry.
Honey and melatonin.
Honey and melatonin. Okay, I understand. Okay, then what I would do is do that, brush the teeth, but then have plenty of, give them at least some relaxing activities to kind of counteract the brushing of the teeth. Does that make sense? Okay. that makes sense. Yeah, sometimes you have to do one thing in order to do another. And then I'm also noticing your children watch TV videos or DVDs occasionally or sometimes to help them fall asleep, and they listen to music. So tell me about that. Do you think the music is as effective as the videos and the DVDs, or?
Music is more effective.
Is more effective, good.
For sure.
Good.
Yeah.
Is there a way that you could focus more on the music and less on the TV and videos?
But when they are upset, TV is much more effective.
Okay. Okay.
Yeah. So
Okay.
when they're calm and happy, I just put the music on.
Okay.
But when they're making fuss and seems like doesn't want to go to sleep, then I put the videos on.
Okay. And tell me about the videos you use. What kinds of videos?
Winnie the Pooh. Or
Okay, Winnie the Pooh, right. Okay, and do you find that sort of calms them and helps them settle? Okay, and this is a really good, important observation. I mean, you're doing a great job as a parent, by the way. I'm really impressed, especially with twins. You really seem attuned to what your kids need. And it sounds like when they are worked up, they really need that Winnie the Pooh video to bring them down. I'm not arguing with that. I think that's great. The thing I would have you think about, or the concept I would have you think about, is whether you could move that earlier in the evening, right? So that then they can calm down if they need that, but then you still have some time before bedtime to put the music on or do some other things. And that way, they're not getting the video and the light and everything right before bedtime. You know, so maybe do both. Maybe do the video and then transition into the music. And the video you do it in that way so they'd still have some time before bedtime free of the video. And then my other question with the music is, do you let the music kind of play until they fall asleep, or do you turn it off before they go to sleep?
I wait until they fall asleep.
Okay. Do you ever have problems with them waking up at night and wanting the music?
When they wake up middle of the night, they wanted to play, or like twin B, like jumping on his crib.
Mm-hmm.
Like he's fully awake and just start jumping. And they don't really asking for the music. Sometimes they ask for the video, but they never really ask for the music.
Okay.
They are non-verbal, so
Yeah,
it's hard to
yeah,
tell, but-
yeah. So we're going to talk about that after the break, is the idea of the night wakings and the music and what you can do and how you can maybe potentially even put like a continuous CD player on or something to see if we can keep them asleep. Because sometimes the trick is to keep them asleep, because once they wake up, then then things are out of control. Well, I think you're doing so many things right, and hopefully coming today we can give you a few other suggestions that will make a big difference for you. So let's give her a big hand. Thank you for coming up. Hi, Pam. So let me take a look. How was it filling this out for you?
Well, a little bit more difficult because we have 4 children, so we have to fit our one that's on the spectrum within the other 4. So our bedtime routines lately have been not the best.
Can I get you to put the microphone just a bit closer to your mouth? Thank you.
So this is really helpful. What you listed, first of all, you checked off all the different activities, and it looks like most of them do occur, maybe with the exception of the singing of the quiet songs. And then there weren't really any others. So this fit pretty well, what you do. That's great. And then taking a bath is easy and stimulating, okay? And then washing hair is easy and stimulating. and then changing into PJs, getting a drink, brushing teeth, using the bathroom are easy and relaxing. And then the reading is easy but stimulating. I'm curious, why do you think the reading is stimulating? Is it?
Because it gets his mind going on the story, and
Yeah.
then he tends to focus on that, and then that's what he's thinking about when he goes to bed.
Right, exactly. That happens to a lot of us as adults too. If we've got a really good novel we can't put down. And do you ever find that if he were to read a familiar book, that would happen less or not necessarily?
I don't think so.
You don't think so? You think regardless
Yeah.
of what he reads. Okay. And I'm curious, in terms of his bedtime routine now, what is he currently doing? Do you have a bedtime routine in place right now, or?
Well, for us, generally, we do our baths right after supper, and then I will sit down and read with him or them, whatever, while the others are watching a show or whatever, just to calm down after supper. And then right before bed, we brush our teeth, go to the bathroom, get a drink, and then into bed, hugs and kisses from mom and dad. Hopefully good night, and lately, no.
Right, right, okay. So it sounds like you've really, before you said the lately no, I was gonna say, wow, you've really gotten organized.
4 kids, yes.
Right. You've put the reading, the reading, which is stimulating early on, the taking the bath is even earlier on, and then you put all the relaxing activities and easy activities next. But the best laid plans go astray. Even doing that, you're finding. So tell me what's going on. So after you do all of that, does your child seem relaxed?
He does.
He does,
I
okay.
think it's more his younger siblings who are twins.
Yes.
So, and they share a room, so right at this point, that is our problem.
Right.
Because then they get going, and his room's right next door. Our problem with him is that his hearing is super sensitive, and so as soon as he hears anything, he's awake or he's having trouble going to sleep.
Got it. So if it weren't for them being next door, this might be working really well.
Yes.
It's one of the key questions I always ask when we put the bedtime routine together is the child actually unwinding? That concept we talked about this morning of trying to turn your brain off, is the child calming down? And I think in this case, it is successful.
yeah.
The challenge is the siblings next door. So that's kind of a separate issue. So the question I would have, so he's how old?
He's 7 now.
And how old are his siblings? 5, okay. So the question would be whether we could put a bedtime routine together for them,
That's
right?
what we're thinking. Well, we
Yeah.
have we have
Yeah.
a pretty strong bedtime routine. It's just getting them right. They're just, I don't know, it's that age, I guess. They just think bedtime's a joke.
Right.
Playtime.
Would they be able to go to bed earlier than him in terms
That's
of?
what we're thinking, because
Yeah.
right now, because he wakes up through the night, that's his issue, is that he does not sleep through the night. He wakes up about 3 o'clock and he's in his room. He doesn't wake us up, but he's awake, and then you can tell at school and whatever that he hasn't had a good night's sleep. So we're thinking, from what we've gotten from you, is that we'll probably extend his bedtime from 7 to 8, and then hopefully the twins will have settled by then, and then he can get in and do his thing.
Yeah, that's what I would aim for, because if you can get them to bed and maybe use the bedtime routine worksheet with them, get them settled down, let him do an activity that's calming, that isn't stimulating, and kind of get him through. Or the other way to do it is he could be doing his reading while you're getting them to bed, and then as soon as they're in bed and settled and asleep, you can then you could finish the rest of the bedtime routine with the PJs, the drink, and everything else. That might work. And then there's a 4th child in all of this,
He's
right?
the older child.
Right.
He's pretty laid back.
He's pretty laid back.
Yeah.
Okay. All righty. Very good. Okay. So this was an example where we really didn't change very much at all. You're doing a great job with it. It was just trying to figure out how to work it with the other kids.
Mm-hmm.
Okay. Excellent. Thank you, Pam.
Thank you.
I wanted to share one of the questions I got during the break, which I thought everybody could benefit from. It was a child who had trouble winding down no matter what. It was a 3-year-old, very articulate, high functioning, was actually enjoying a yoga and meditation type video or audio before bed, was getting into it, but it just didn't relax him. He was still really wound up, even listening to this. And really any activity tried was stimulating. And so what I suggested is pairing that activity, which I thought was great, the idea of doing a yoga meditation type audio, pairing it with a small dose of melatonin, like 1 milligram of melatonin, with the idea that the melatonin would allow the child to relax and learn, because they had really tried every activity. And it wasn't like he didn't enjoy it, the activity, it just, he was still wound up after it. And then the idea was, if we could pair it with the melatonin, it would allow him to actually calm down and relax, potentially absorb more of the information from the audio and the sounds on the audio. And then you could try to withdraw the melatonin over time, but it would give him the opportunity to learn to relax and incorporate that relaxing activity into his routine. So, just something to think about with that. Any other questions before we take a break? Or anyone who wants to do one of the questionnaires? Let me ask them and then yeah. I'm sorry, you had yeah.
You had listed up there sleep anxiety. Are you going to talk at all, do you ever do any, if they're having a ruminating thought before bedtime, do you do anything like thought replacement of a more neutral thought or anything with that with higher functioning individuals?
That's a good question. So the idea is, with sleep anxiety and ruminating thoughts, particularly if the child has language, do we ever replace it? And I do. I think I would put this under the category of, either building into the bedtime routine or even apart from the bedtime routine, outside of it, before you start the bedtime routine, trying to come up with substituting activities. So there's some really nice books, there's some really nice tapes that you can make available to parents where, one of them is just 5 good minutes in the evening, where there are sleep sections that just have these mantras where the child can basically take all of their ruminating thoughts, put them in a balloon, watch, visualize the balloon drifting off. I've used that on occasion with the higher functioning kids, with the kids with a lot of language. And it's been very successful. What you want to do sometimes is have them practice it at other times during the day, and then either build it into the bedtime routine as one of the earlier activities, or make it like a pre-bedtime routine activity where they engage in it. It kind of winds them down. It helps them separate the day from the night, and then you can move forward with the rest of the bedtime routine. I want to start out by talking about bedtime resistance and night wakings, and then we'll talk a little bit about some of the work we've done in our research and our results, and then kind of conclude with where do we go from here, and I'd love to get your input on that, and then we'll wrap up with any last questions and answers. So sleep resistance, it's a very popular topic in the literature. There's been a lot of emphasis on different methods. You might have heard extinction used, or modified extinction, or bedtime fading with parental presence. So I'll try to use those terms as I go along so that you understand, if you read books, what I'm talking about or where these are coming from. But I'll also just talk about the general technique. So when we talk about sleep resistance, we're talking about a child who's really fussy and resisting and not wanting to go to bed, and this can take the form of just being fussy or crying or screaming or whatever. It can be pretty extreme, and it's very helpful. It's very challenging, particularly in a child who has limited verbal skills, to understand exactly what's going on. But there are different strategies that will work. And the first is to really go back and think about daytime habits. I think, Osmond's point was very well taken. Don't forget about the daytime. So be thinking about, is there anything I can do during the day with exercise, with minimizing light, with minimizing caffeine, because that will feed into bedtime resistance. The other thing that we mentioned was the timing of sleep, and making sure that sleep isn't too early, and also that sleep is at a consistent time every day. That will allow the child's melatonin levels to kick in, their natural melatonin levels to kick in. So what I have not put up here is extinction. Extinction, or at least complete extinction, is been referred to in the literature as letting the child cry it out. And I don't want to make it sound like it doesn't work. It does work in certain situations. It does work oftentimes in typically developing children. And I even have colleagues who work in sleep and autism who say that it's very effective in autism as long as the parents will buy into it. With that said, I have not found it particularly useful in my practice or when I give workshops to talk about having the child in the room, they're making a fuss, the parent is instructed to leave and let the child settle themselves and go to sleep. And the reason I haven't had a lot of success with it is the parents are not that inclined to do it, they're not that excited about it. And I'm not sure it works for every child. I mean, a child who's very anxious, a child who's nonverbal and can't articulate what's scaring them or what's stimulating them, it really puts some barriers up. And I think that as parents of children with disabilities, we're prone to not want to do anything that might harm our child or cause our child to have distress. So what I've found over the years is it's not a strategy that I use very readily. There's something called modified extinction. Oh, and you may be wondering, what does extinction mean? Where did it get the word extinction? Extinction has to do with taking a behavior that's been going on, that's been learned, and extinguishing it. So extinguishing, for example, the child's calling out and needing the parent to be there. So modified extinction is a form of the same thing, but you're letting the parent go back in at hopefully increasing intervals of time. And one of the ways that this has been worked out in a way that works for the parents, works for the child, is to say, excuse me, and to say to the child, whether they're verbal or not, oh, excuse me, I forgot something, and to leave and then to come back a few minutes later. And this makes it, I think, a little bit easier for parents to swallow. And again, I've had people tell me this works, and it even works in autism. So it's one option. What we've found over the years and what we've put in our book is we do recommend that we sometimes can try modified extinction. So, that the child is in the room, the parent leaves, they come back, but they let some time pass before they come back. You let that time be longer and longer. At first it may be just a few seconds, and then it's longer and longer, and the child learns how to fall asleep. As an alternative, though, to either complete extinction or modified extinction is something called parental presence with fading. So I call it the rocking chair method. And what it is having the parent in the room, but with their back or at least their side to the child. So that the child sees the parent, the child is comforted by the parent. The parent is comforted that they haven't abandoned their child. The parent's sitting in a comfortable chair. It could be a rocking chair, it could just be a regular chair, but it's something comfortable. The parent has a book or a magazine with them. And the parent is prepared to know this may not happen overnight. This may be several days. It may take a little bit of time for this to work, but it will eventually work. Best to maybe not do this the next day that the parent has something important at work, if they work outside the home, or even on a weekday, maybe do it on a Friday night or a Saturday night to start. And the idea is that the child falls asleep, but the parent is in the room with the child aware that the parent is in the room. And then the parent, if the child starts calling out, can say, go to sleep, time for sleep, something very calm, something, reassuring, but not a long discussion or anything that reinforces the child, but is still present. And then over time, can move the chair closer and closer to the door until they're out of the door. A modification is if the child is co-sleeping and the parent would like to eliminate the co-sleeping, it can be done with a mattress. So the child's mattress and the parent's mattress are next to each other, or the parent lies on the bed next to the child or on the floor next to the child, and then gradually moves away until the parent is out of the room. So it's a gradual fading of parental presence. The parent needs to stay calm, but it's oftentimes easier and less skill-provoking than the traditional forms of extinction. So that's one thing we do. This works regardless of the level of the child in terms of their verbal skills. One thing we really try to do, particularly with the kids who have language, is institute some sort of morning present, morning sticker, basket of presents, some sort of reward. Also telling a story about, we need sleep, everybody in the family sleeps, your dog sleeps, your cat sleeps, your doll sleeps, and kind of explaining that everybody needs to kind of sleep in their own room and learn how to fall asleep on their own. And that can make a big difference. Sometimes we'll have the child have a doll, and we'll have the child put the doll to bed, learn how to teach their doll to fall asleep on their own without them present, and then the family can learn, the child can learn how to fall asleep without their parent present. And a first step in minimizing night wakings, the other big concept I wanted to get across, is to help the child fall asleep on his or her own. And this is this principle. Mark Durand has talked about it. It's called back to bed, or first, it's basically begin at bedtime. So the idea is that a child who can fall asleep on his or her own can go back to sleep on their own, just like us. The idea that anything we've become dependent on to fall asleep may not be there when we wake up. So the classic story for the adult is the TV. We fall asleep with the TV on, and then we wake up, and if the TV isn't on, we become fully awake. We wake up many times a night. We are not aware we're waking up. We go right back to sleep. And so it is with our kids. They wake up, they go right back to sleep. But what will keep somebody from going right back to sleep is missing whatever they had when they fell asleep. So an item that we're dependent on or our kids are dependent on, if it's not there when we wake up, we're more apt to turn that wake up into a permanent wake up rather than a falling back to sleep. So responding quickly to distress, comforting and reassuring, yet remembering to keep the interactions fairly brief and fairly boring so there's no reinforcement for the child, or avoid over-responding to subtle little noises that might be coming from the monitor. Do allow the child to kind of soothe themselves back to sleep whenever they can. Use visual reminders. And that could be repeating part of the bedtime, if need be, repeating part of the bedtime routine. Choosing realistic goals. Sometimes a realistic goal is not, a child who's co-sleeping, who's still having a lot of resistance and a lot of night wakings. Maybe you don't move into a different bedroom right away. You still allow the co-sleeping to go on, but you work with the parent to institute a calming bedtime routine and get that in place first before you work on the co-sleeping. And then pairing with rewards. I wanted to say one more thing before I go on to the bedtime pass about this. This is where the kids who are overly sedated on medicines it can get you into trouble because they're so used to falling asleep with the medicines that when they try to, go back to sleep when they wake up at night, they're not able to because they never learned how to fall asleep on their own. So that's where actually decreasing medicines at night to promote sleep. Let's say a child is taking several medicines at night to fall asleep. They fall asleep fine because they're pretty much sedated from all of these medicines, but then they're waking up consistently every night and they can't get back to sleep. Actually working on decreasing some of the medicines and instituting a bedtime routine at bedtime, even though you might not think they need it and the parents might not think they need it because they're falling asleep fine at bedtime with these meds, instituting the bedtime routine and then trying to cut out some of these meds can be extremely effective because the meds are interfering with their ability to learn how to fall asleep on their own. And then when they wake up in the middle of the night, it's because they haven't learned how to fall asleep on their own. Does that make sense? Okay. Question? I'm sorry, if a child... Oh, like the mom or the dad? Yeah. That's a really good question. So if the child prefers one of the parents, what will oftentimes happen is like one of the parents will be stricter and then the child will be smart enough to realize to go to that other parent. That's where really, getting the parents together and taking time to talk to your spouse and working through that. It's easier said than done. It works well if the parents are in the same house and household. In the cases of separated parents, it's been really problematic, but we still try to get them together so that they have, a consistent routine. So the child is doing the same thing regardless of which household they're in.
Because, like, if his dad puts him to sleep, he just screams bloody murder, and it takes forever to go to sleep, but then if I go, he's out. So my husband will say, you do it.
But let me make sure I understand this. If you put him to bed, you have to be the one who has to go up when he wakes up. Oh, okay. And tell me, when he goes to bed at night, does he have a bedtime routine? And he is. Okay, and he's falling asleep well at night? Okay, good. But they're not frequent, they're once in a while.
Yeah, but sometimes
Yeah.
it's really lucky.
Yeah. You might want to look, it sounds like what you're doing though is effective because he is able to go back to sleep when he sees you, is that right? Yeah. Okay, so you need to find something else to get your husband to do to make it up to you. It could be laundry, it could be dishes, I'll let you work on that. But in this case, just think of something you really hate doing, that he can do in that place. Yes?
Would using the melatonin or the
gabapentin
in conjunction to facilitate the extension, would that be useful?
Yes. It certainly can be. I think the trickiest part with using these meds, regardless of whether you're going to do modified extinction or the rocking chair or whatever, the biggest challenge is to use them to facilitate and not use them to sedate. In other words, if you use them to overly sedate to the point that the child doesn't learn how to fall asleep on their own, it's going to be hard to take them away, and even worse, it might not help with the night wakings. So the challenge is to use enough of a dose that kind of takes the edge off and allows the child to calm down and fall asleep on their own. But you want them to do the process of falling asleep on their own. You don't want the medicine to kind of help them fall asleep on their own. In other words, it can facilitate it, but you want it to be ultimately the child falling asleep. It's tricky to know what that is, but it's using too much, it's using the right amount of medicine, not too much medicine. My experience over the years has been that people use too much medicine, or they come to you on too much medicine because most of the pediatricians, and even unfortunately the sleep specialists, and again, I'm not talking about Vancouver, I'm talking about our country. Most of the physicians and most of the sleep specialists tend to over-medicate and not necessarily work with these behavioral principles. So this is the bedtime pass. I mentioned it earlier when we were doing the scenarios, and I think it really works very well for some children. It works better for kids, or it really works well for kids who have some language. And it seems like it works best for kids, in my experience, who are like 4 to 9 years old or 4 to 8 years old. And what it is it's simply a laminated card that you can put in a little holder, and it can be something the child really likes. It could be a teddy bear, it could be a dinosaur, it could be Dora the Explorer, it could be the car, one of the cars, Lightning McQueen from Cars. It can be anything the child really likes. And this is the antithesis of extinction. This is where the child is actually being rewarded for doing something positive as opposed to not rewarded for doing something that you don't want. And what it is it's very simple. It's a little card. It's very much like a token, if you've used a token system. We have a story we've written where the child is given the pass. They're actually, either they construct their own pass or they pick a pass from several choices. And they are told this is a ticket. People need sleep. Sleep helps people feel refreshed and have energy during the day and stay calm. So sleep is important. My parents want to help me get a good night's sleep. They want me to be rested, calm, and do well in school. My parents have made a bedtime pass to help me. They will give me the bedtime pass when I go to bed. It's like a ticket. And then if I need anything, if I need a glass of water, if I need to get out of bed, if I need a second good night hug, I need to trade in the bedtime pass. So I give the bedtime pass to my mom or dad. They give me a hug. They give me a drink of water, whatever. And it's really up to me to choose. I can either surrender the pass and get what I need, or I can decide to hang on to the pass and then not ask for the drink of water, not ask for the extra hug. You know, it's still okay to hug your child before they go to bed. This would just be that extra stuff that takes a long time to get them to go to bed because they keep asking for stuff. Or if they wake up in the middle of the night and they call or they come to your room, they have to give them the pass, and then you bring them back. So the way it works is, and this is a modification, this pass was developed by a pediatrician named Pat Fryman. We put a modification on it, which is basically being able in the morning, if they don't use the pass, to trade it in for something really special. So the idea is that that really special thing could be, it doesn't have to be expensive. It could be a warm blanket from the dryer or a warm towel if the child likes tactile things like that. It could be a wrapped present from the dollar store. It could be a sticker, and then when they get 3 stickers or 6 stickers or whatever, then they can get something really good. But it's not really a bribe. What it is this is very concrete. We know kids with autism love visuals. They love things that are concrete. And then the other thing they really love is control and a sense of control. And the idea is that this allows them to decide. They're in the driver's seat. They can either give them the pass and get the hug or get the glass of water, or they can hang on to it, and then in the morning they can get their presents. So I use this with my son, and I remember he would come. into our bedroom and call out like 2 in the morning and say, Mom, I need this, I need this, I need a hug, I need a glass of water. And he didn't really need any of that, but he just needed us. And, you know, we had increased the amount of things we did with him during the day and during the evening, and he still really needed it. And what we found was we gave him the pass, and initially, and we gave him the story. Initially, he would still come to our room, and we would take the pass, and we would go back to bed, or he would call out for something, and we'd take the pass, give him what he needed, and say, we'll try again tomorrow night. Well, one night, we woke up in the morning, and it turned out he hadn't found us during the night. And I said to him, Daniel, here's your wrap presents from the dollar store. You can pick out a reward. Why are you getting a reward? And I thought he was going to say, because I did not have to use my bedtime pass. I was able to sleep through the night. And instead he said to me, because I was not scared. And it was really interesting because I think in his mind, he was equating, he was scared, he needed us, but he also knew that he could hold on to this and he could make a choice between needing us and getting us and basically keeping the card and turning it in for a reward. So we gave him the reward, and like 3 days in a row we gave him the reward, and then we just sort of forgot about it, and he forgot about it. Maybe he had all of the stick figures he wanted from the dollar store and he was good, but in any case it just sort of went away and he slept through the night. So it didn't take very long at all, and I felt really good about it as a parent because it really seemed to sit much better with me than punishment of any form, or it was a very nice way to, I felt empowered, he felt empowered. I was really giving him the choice for what to do. And I think that at some level, that was a very beneficial thing for him in his development to be able to make a developmentally appropriate choice about whether he needed to come find us or whether he could just hang on to his pass and trade it in the morning. So that's the bedtime pass. It doesn't work for everyone. It's got to be the right age and the right verbal level, but it does work for a lot of kids. Yes?
What if this kid is waking up more than once?
We've actually experimented with more than one bedtime pass. We've given 2 bedtime passes or 3 bedtime passes. And the idea is there may be multiple times the child is waking up, and it's not realistic to have them not wake up at all. But if we can decrease the number of times they're waking up from 5 a night to 2 a night, then that would be pretty impressive. So maybe we give them 3 bedtime passes, they use up 2, but they don't use up the 3rd. And then we've made significant progress because they've gone from 5 night wakings to 2 night wakings, or 2 bedtime resistance type episodes to 1 bedtime resistance and 2 night wakings, or whatever it is. So yeah, I think experimenting with more than one. The question I thought you were going to ask, so I'll just say it, is what if the child is waking up and is actually awake in their room and not necessarily going back to sleep? It's just that they're not waking you up anymore. And what do you do with that? Because you don't want your child necessarily awake. And the answer I would have there is, if you're not interacting with them, there's a higher likelihood they're going to be able to go back to sleep on their own, particularly if you don't have the iPad in the room or any stimulating toys or things in the room. So number one, it does promote them going back to sleep on their own. And then the second thing is there are kids who are going to wake up and not be able to necessarily go back to sleep. That may be all the sleep they're going to get, all the sleep they're going to need. We don't know that for sure, but sometimes it's what a family needs to do in terms of you getting the rest you need. And this is much more helpful than, the child, for example, having to go and find you and waking up the whole household. So it's a tricky thing. I'd like to say that I never say to a parent, let me see if I can restate this. I have tried to increase sleep. I have tried to, parents have come to me and said their child sleeps 6 hours and then they're done. And I've tried to use medicines or other strategies to increase their sleep duration. It's not always successful. And then sometimes we're dealing with, well, rather than the child sleeping from 8 to 2 and then being up, let's have the child go to bed later, let's have them sleep from 10 to 4, and then they have another hour while the parents are getting their last bit of sleep, and then at 5 a.m. everybody gets up. So the bedtime pass can help with that as well. I mentioned the limited verbal skills earlier. This is really helpful. It's one of the toolkits. We had developed, as a sleep committee, we had developed the tools for the bedtime routine and the bedtime pass, and we were basically asked by parents of children with limited verbal skills to come up with a tool for them. So we're very proud of this. This is actually the work of my colleague Terry Katz at Colorado, who's one of her special interests is she's a psychologist, is working with children with limited verbal skills. So she's been very successful with photos, with object schedules, with cues in the environment. She'll either put the objects, the real objects, on a wooden board, or she'll make little boxes that the children can go to each box and pick up the object and do the bedtime routine in that way. So they'll start with the roll of toilet paper, the soap, the shampoo, the brush, etc. And then lots of sensory strategies, working in collaboration with our OTs, as was mentioned earlier. There's a lot of options here for rocking, swinging, snuggling, massaging, music, and other things mentioned here. I wanted to mention again our toolkits that are all available on the Autism Speaks Autism Treatment Network website. There's a very long email web link, or you can just search for Autism Speak Sleep Toolkit, and they'll come right up. And in addition to the child one, we now have the teen one, we have the quick tips, we have these visuals. You should have a lot of the materials, but there's other things out there, like on visual supports. There's a really nice toolkit that you can go and download for free. They're also available in Spanish. Yes?
Do you have problems with the sleep log on this toolkit?
We don't have them yet on Autism Speaks. We'll be uploading those soon, but I think we can make them available to anyone who's here today. You have that, I believe. Yeah, if you don't, let me know. And we'll get those available. So you can get the sleep log through ACT, through ACT. And then I just wanted to talk about the research we've done, because this kind of leads into getting your... Just wanted to talk about the research we've done, because this kind of leads into getting your input on where we can go from here with this. With funding from the Autism Treatment Network, AIRP, it's called, Autism Intervention Research Program, we're able to carry out a two-phase study in which parents of children with autism who met the DSM-4, at the time it was the DSM-4 criteria, with a confirmatory ADOS, the Autism Diagnostic Observation Schedule, participated. They were ages 2 to 10 years. The children were ages 2 to 10 years, and they had difficulty falling asleep 30 minutes or greater on 3 or more nights a week. And in phase 1, they were given a sleep education pamphlet. It was the same one that you see here, except it wasn't as pretty. It was just the materials without all the beautiful visuals. But the text was the same, the content was the same. Or they were given no intervention. And then in phase 2, 80 parents were randomized to either 2 2-hour sessions in a group or 1 1-hour session in an individual setting with a trained sleep educator. And in these sessions, we went over the basics of sleep hygiene and sleep education that I showed you today. We got sleep and behavioral measures at baseline and 1 month post-treatment. And the curriculum was reviewing the CSHQ, reviewing the fish, going over daytime and evening habits, sleep needs, timing, calming bedtime routine, saying goodnight to the iPad, minimizing bedtime resistance, and optimizing parent interactions with the child and upon awakening. And what we found, we were very pleased that the time to fall asleep in minutes, whoops, oh dear, sorry about that. The time to fall asleep in minutes, as measured by actigraphy, was significantly improved. Hold on. There we go. Was significantly improved in the children whose parents did either the individual education or the group. So blue is baseline, red is treatment, and you could see the improvement was about 22 minutes in the, actually it was a little longer than that. It was like 24 minutes in the treatment compared to the baseline. And then for both group and individual sessions. The kids whose parents received the pamphlet or who had no treatment did not improve. Actually, the ones who received the pamphlet improved somewhat, but it wasn't statistically significant. So we do statistical tests to measure improvement. And then we also found that in the group and individual education sessions, in other words, where a trained therapist worked with the family, we saw improvements in all of the insomnia domains on the Children's Sleep Habits Questionnaire. The sleep disordered breathing and other domains did not improve, which was good. So the parents weren't just checking off that everything was better. They were selectively better in the areas that they were getting the education in. The repetitive behavior scale revised also showed improvements in restricted behavior and stereotype behavior with treatment. The child behavior checklist showed improvements in attention and anxiety. The pediatric quality of life scale, total score improved with treatment. And then this parenting sense of competence that I mentioned, which looks at a parent's level of self-efficacy and satisfaction with their parenting, improved as well in both the group as well as the individual education. So we were really pleased with this, and where we're going next is to try to develop and test innovative models for delivering these behavioral interventions in community settings. So this may be a therapist, as I mentioned, in a community setting who uses our manualized approach. We can basically do the sleep education in 1 hour with the individuals, or 2 hours and two sessions with the group, or the books to teach parents on their own, because these therapists are not always available in community settings. And we want parents to be able to pick up a book and do it themselves. And the idea of the book that will be coming out is we've tried to take the material in here and expand upon it, where we actually teach parents, for example, how to fill out the fish, fill out the CSHQ, fill out the bedtime routines worksheet, analyze their responses, figure out what they can change, and do it all on their own. And then we also want to do more study of integrating behavioral interventions with pharmacologic treatments. So, for example, this idea of the melatonin may be more effective, or I should say the behavioral intervention may be more effective if paired with the melatonin or other medications to try to take the edge off the child and allow them to implement the strategies. And then we also are starting now to expand our work to adolescents and young adults. One of my colleagues has a really neat behavioral education program with adolescents and young adults sponsored by the Organization for Autism Research. And what she's doing is she's doing relaxation techniques, she's doing meditation, she's really working with both the child and the parent, either together or separately in different sessions, to really get the child to do deep breathing and relaxation and make a difference. And we've seen some improvements already in that area. Please let me know if I can answer any other questions. Yes?
I just have a more socially aware that they're different. And because of that, they don't want to try anything. So they don't want to try the visual schedules. They're just done with it. They don't want to have anything that's different. They don't want to try the way fast. And I find it's hard for those type of kids to get them, like it almost seems like the more it's the more they say, we don't want to do any of this stuff. It's making us look different. There's in their own home, they don't want to because they know their parents are wanting to do it, even though it's going to help them. And I find it really hard with those kids to get them. It's like, what would be the best way? And they need that sleep. They need that way.
Yeah.
To get it. They need
Yeah.
that.
Are you talking about teens, or are you talking about older school age?
Usually you find our kids who are age 9, pre-teen age kids.
So in those kids, so the question is, what do you do with 8, 9, 10, maybe a little older? They're really high functioning, they aren't sleeping, they also don't want to be labeled. My kids are very much like that. They're very sensitive to the autism label, and they don't want to stand out. They want to be like everyone else, which is really healthy in a way. I think what I would do in those cases is I would go to the typically developing kid literature, and I would find books and pamphlets that are not directed at kids with autism. There's like a book I love it for 7, 8, 9-year-old girls. It's called What to Do When You Dread the Bed, and it has different worksheets, and it's really a very clever book. And I would de-emphasize the autism, and I would emphasize the sleep, and really think about, because a lot of kids have trouble with sleep. It's just not limited to autism. And I would probably de-emphasize the visual schedule and look more at just some general bedtime habits type things, and see if you could get something out of that. So basically say, this isn't specific to any disability or anything. This is, very common in kids in general. Let's not think of this as an autism problem. Let's think of this as a sleep issue. But this could give you, and then the other thing that I work with my kids on, not my kids, but kids I see in clinic who have sleep issues, particularly the teens, even if they're typically developing, is what are your goals? What's important to you? So for a 14-year-old boy, it might be being able to get up and be able to play sports in the morning, and being able to wake up to get and do their sports. Or for a girl, it might be getting straight A's or whatever. We really have to think through what motivates the kid, and it's not always easy. But I guess I would de-emphasize the autism, and I would find some goals for them that are worthwhile, and that they can buy into. Yeah.
I have some questions about, you spoke earlier this morning about mouth breathing, I think in relationship with sleep apnea, and I'm wondering what information you have about kind of the quality of sleep or sleep waking with mouth breathing versus nose breathing.
Okay, so the mouth breathing is oftentimes a sign of nasal congestion. So that's kind of the critical thing here, that a child who has either congestion from seasonal allergies or who has a structural problem with their nose increased, there's turbinates in there, there's different nose structures, that's probably all I need to say for the purposes of today, is going to be a mouth breather, because they're going to have some level of nasal obstruction, nasal allergy, inflammation of the sinuses. So the idea would be that child could be more prone to have sleep disordered breathing. So it could be a symptom that you would look for. The treatment sometimes can be pretty benign. It could be antihistamines, or it could be Flonase, or it could be wearing a sinus, wearing a Breathe Right, or rinsing out the nose with sinus, cleaning out the sinuses like a sinus rinse. So all of that could be effective, but the first step is just to be aware of it and to realize, oh, this is someone who's breathing out of their mouth. Maybe there's a sinus problem going on here.
So is there a relationship between increased night waking with someone who is chronically congested like that?
That's a good question. I think there might be. I think anything that interrupts sleep could be a trigger. So the night wakings, so the night terrors, sleep terrors category, sleepwalking, is felt to be a genetic predisposition, and then adding to it is either an external stimulus or an internal stimulus that wakes you up. So that could be a full bladder, it could be noises in the house, it could be nasal congestion. So, and then the non-sleep terror, sleepwalking category, just the night wakings category, anything that wakes you up at night could put you back to sleep. So I'll give an example for us as adults. I'm really protective of my sleep. I really want to sleep well at night. So I oftentimes will do a sinus rinse before bed and make sure I've cleaned, I've rinsed out my sinuses because I tend to get congestion. I'll wear a Breathe Right. I'll have a white noise machine going. I'll do all of these things because I'm one of those people, if I wake up, I'm done. I think about work, I think about all the things I have to do. So for me, it's really important that I minimize night waking in whatever way I can, because I tend to be a light sleeper. So I would say it couldn't really hurt to try all the, try those different things. And those are simple things a pediatrician can do. Anything else? Yeah. Oh, that's okay. We'll have time for both.
My son had sleep apnea when he was very young, 4 months till about 2.5 years old, and he slept with CPAP for that whole time. And at that point, he did sleep studies every several months to see how he was doing. In 2.5 years, he came off the CPAP, and he did really well past all his sleep studies for about 4 years. He's 6 now, and the last sleep study he had was about 3 months ago, and he failed it, not as badly as he failed it as a younger child, but they wanted to wear the mask again, but now he's 6, he won't wear the mask. It's impossible to keep it on him. But in between all those 4 years that he didn't have sleep apnea, he still had sleep difficulties. So now I'm at the point where I'm trying to figure out, what do I do next? What do I do first? Because sometimes he falls asleep in the bath 6:30 at night, sleeps until 2-3 in the morning, and then he's up until 6, falls back asleep, and I can't wake him up for school. So that happens about, say, 70% of the time. And the other 30% of the time, he won't fall asleep until midnight, and he'll sleep most of the night and be up really early. So I think there's several things going on here, but I don't know which one.
Yeah, so dissecting it out, and yeah, exactly. So one question I would have is, do you think he's having trouble with the CPAP because he's not sleeping, or is it the mask is uncomfortable, or just having to wear? Okay. Okay. Okay, yeah. So, and that was what I was going to suggest, is have him go to sleep and then put the mask on. So I would really work with the home care do you guys have home care companies here that you work with that are assigned? Okay, you work just with your pediatrician's office or your sleep specialist's office? Is that?
Yes, my pediatrician's in a different, I live in northern British Columbia, so my pediatrician's in another town, and usually we come to Children's Hospital in Vancouver.
Okay, and they prescribe your CPAP here?
Yes.
Okay, so that's actually even better. I would go back to the clinic and say, look, I'm having trouble having him wear this. Is there anyone who could work with us who can kind of desensitize him? So the key is to make sure you've got the most comfortable mask that you possibly can, because some of them aren't even masks anymore. Some of them are just things that go in the nose, like nasal pillows. So really getting the most comfortable thing. I was just at the sleep meeting, and they have this padding for the mask. It feels nice and soft and smooth, and it's very sensory pleasing. There's all different things that they can do now. CPAP has been around since 1980, 81. So every year there are more and more advances. So I think finding something that he can actually tolerate, that he could wear while he watches TV to get used to. I would start with the mask, because my concern is that until his sleep is regulated and he's actually not waking himself up from the apnea and he's getting solid sleep, it's going to be really hard to make headway with any of the other issues with the insomnia and all. So I really push the clinic and say, I really need some help. I know he needs to use this. What do you suggest? There are alternatives to CPAP for treating apnea, but none of them are that great at this point. There's orthodontic alternatives, there's more surgery alternatives. I mean, going back to the ENT and seeing if there's anything else, you could do that and do the CPAP desensitization. But I would really emphasize, you know, assuming his sleep apnea is significant, which I assume it is, otherwise they wouldn't be pushing the CPAP, I would say you really do need to get a handle on that first.
Do you, and just sort of as a follow-up,
Yeah.
do you know if sleep positioning
So one,
can cause sleep apnea? Because he sleeps in the, like, he sleeps folded in half.
okay.
With his like nose touching his knees kind of thing. I don't know why. So I'm wondering too if that positionally that's causing some of.
So tell me what he does. He's on his on fours.
Like if you lay on your back and then you folded yourself in half with your nose to your knees.
Well, it's interesting because that's something we sometimes observe in kids who are trying to open up their airway. It's very strange, but it depends which position his neck is in. But I don't know. I wonder, I thought you were going to say sleeping on your side versus on your back, because sometimes getting a kid on their back, getting a kid on their side or getting an adult on their side for that matter can help positional sleep apnea, where it's worse on your back and then you flip them on their side with a body pillow or whatever. I don't know. He goes right back. So there are ways to keep him. One thing you could do is go back. I would say go back to the sleep clinic that diagnosed. Look at the sleep study, see if it's related to a certain position. If it's only when he's on his back, there's body pillows, and there's also simple things like just putting a tennis ball in a sock and sewing it to a nightshirt. So he's not going to be on his back because then he has a tennis ball between him and the mattress. So rolling onto his side, that would promote that. And then his sleep apnea might not be as bad on his side as on his back, because when we're on our back, the tongue falls back, everything relaxes, the airway tends to collapse. So that's one thought. Another is the additional surgery. Another is the orthodontic. You said he's had his tonsils out? Oh, he hasn't. But they went to CPAP first anyway?
When he was 4 months old.
Oh. Okay, so I might say this is the time to take his tonsils out and see what that would do. Yeah. Okay. Good. Well, I wanted to say this has been fabulous. The questions have been fabulous, the input. I wanted to thank all of you who asked questions, and particularly the 3 brave souls who came up to the stage and agreed to be videotaped. And I also want to thank our organizers for today. You guys did a wonderful job taking care of me. Thank you. So let's give a hand to them.